Yeah. Ah. Mm-hmm. Here we go. I tell you, people, it's harder than it looks 'cause it's a long way to the top if you wanna rock and roll.
So it's a long way to the top and inspires us. In order for us to understand that one has to strive to be resilient, to overcome obstacles. No one is naturally born with all the skills, but everybody is able to develop them. And it's something for us to inspire, to hear from other experienced guys, especially from Mike today. Okay, uh, and now it's back to you, Ike.
Thanks so much, Milton. I'm just getting my slides up here. Hopefully, you'll be able to see them shortly. Real pleasure to be here. Really, I'm very much looking forward to this session here. Again, the idea really is that I hope it'll be somewhat casual and interactive. We've had a lot of webinars that we've been doing for the last 6 weeks now, and often it's a lot of download information. I realize with well, you've got 700 people already and counting, that it's going to be difficult to get everybody's input here today. But I hope that we'll be able to monitor the chat as well as the Q&A box, and I'll try to do my best to answer them. But I'll rely on our group of panelists here to help me out as well. I just want to start off again by thanking Milton for his very kind invitation to be here. Certainly, it's really an honor to be here with Milton. Milton, you are, as I said, somebody who connects people. You connect the world, and every time I see something happening, you seem to be in the middle of it. And you always are somebody who I think doesn't mind to be in the shadows. But I think you're the puppeteer who basically controls things, which is great. And also, I want to also recognize Brazil, because I think I am pretty sure, I haven't formally counted, but I think of all the countries I visited outside of Canada over the last maybe 5-6 years, I think Brazil is number one. So you can take that to know what I feel about Brazil, even though my Portuguese is very bad. Obrigado. It's something that I deeply cherish, my relationships. And this year we're especially thrilled because we have a Brazilian fellow with us, Tiziana, who I think might be here. She may show herself. And so it's been a pleasure to have her here. She represents your country very well. And I hope that we will, I know she will go back with great skills and knowledge. Hopefully she didn't take all of my negative attributes and my bad traits, but I hope she'll be able to provide some great knowledge back home. Although she hasn't taught me much Portuguese, so I'm disappointed with that. So I know we're here talking about challenging cases and difficult cases, and we will get to that, I promise. But what I want to make this a little bit different is make it a bit more personal in terms of a journey. Also make it a little bit thinking. We show lots of videos, but we don't necessarily get into why we do things or what the reason we do them for. So if you're here today just to see a bunch of videos played back and forth, then I don't think this is the best forum. But if you're here to listen, to understand why we do certain things and why we choose certain things and how we make decisions, which to me is more important, then I hope you're at the right place. These are some of the complicated cases we'll talk about. But like I said before, I want to speak about the journey. And as Tiziana will tell you, I have a minor degree in philosophy because I love to think about things. And this journey is a very crooked journey. There's no straight lines with journeys ever. And I think with COVID, we're all fighting this invisible enemy, and it's given us many challenges. Many of you I know are not working, or you're not in school or educating. Your families are isolated. Is a challenge for you. But as much as it's created challenges, I think it's brought the world together. And this is just a great example about bringing the world together in ways that we never could before, because we were too busy running around from one minute to the next. And that's, I think, the real, I would say, silver lining in some of this, is that it's really made us think about things. And I've used this time to think a lot, to reevaluate things, to just think about who, where, what I'm going, and also to take the opportunity to do new things and innovate. So I call it innovating while quarantining. And if you're not doing something different or not planning to do something different once you get back, then I think you're not perhaps taking as much time as you can. So this is basically our new clinic that we built at Mississauga in Toronto, Prism Eye Institute. It's a big clinic, and in the middle of March, basically everything went dark. This just to tell you what's been going on here. Everything went dark, and so we had to rearrange the clinic just to see only urgent patients. We just work in a very small area of clinic, and we have really rapidly moved into virtual care. In fact, we built a virtual care platform with my team in less than a week, incredibly, to do this and get it online and go. But no question, there are days and times when we feel there are a lot of darkness. I think we've all handled it differently. For me, it's just the time has gone by so fast. And I just woke up this morning. This is from this morning. Those of you who are on Instagram know this because I posted it. And I had to finish my slides. I had to finish a couple of papers. And I was in a rush. I'll admit it. I was in a rush. As you can tell, I don't even have my hair properly done. I just put it in a quick ponytail, which is easier now with longer hair. But I was stunned by looking out my window and I saw the brightest reflection from the lake. And I went and I stopped and I went to get to my camera to take a picture. And I would have never done this in this way. I would maybe gone when I'm in my car on my way to work and take a picture, but to take the time to reflect on that. And this is where I'm hoping that you're taking the time to come up with the right ideas. I think that there's so much that is floating around out there in our heads that we can do that. Many of us have, of course, kept in touch with webinars. And remember, ideas are the source of creation. Coming up webinars and working together. This was on Saturday. We had a wonderful time, wonderful event that went very well, and many of you were there. And certainly has brought us together. And I think social media has been incredible. But let's go back to that journey, because again, I'm focusing this on really what is meant to be toward residents and fellows. And Milton's going to give me some leeway and direction from that. So we have a lot of professors here. I think we have a lot of academics here. And yes, we are basically always looking at our textbook. This is the way we start, and we follow the textbook guidelines. We read the books. We go to the traditional learning approaches. We follow step one, the whole see one, do one, teach one approach as well. And that certainly can take you somewhere. But if you want to do something more, if you want to be more than just the usual, then you have to remember that you are the most powerful weapon in learning. And that's you as the human factor. And that's the ability to use your own knowledge and your own emotions and your own social behavior and your own way of thinking to really improve yourself. And this doesn't mean bringing in ego, because unfortunately in our area, there's a lot of ego. But what I'm really referring to is I'm referring to the human spirit. And I know it sounds corny because it's not scientific per se, but if anything, gives us an example during this time period when we're all stuck because we have no scientific way to treat COVID necessarily. I think where you see the brilliance out there, like the sun shining, is the human spirit. When you see humanity coming together, and when you see people coming together, making new acquaintances and friends, and really doing things that we would not normally do. So I just hope that we think more about our journey. We think about where we're going, where we want to go, and I hope you'll make it count. And I hope you'll think about taking in everything around in your surroundings and not wasting the moment that you're in to do that. And why is this important? Well, it's important because we do this every day in the OR. And for me, the team is very important. And I just want to give a credit to my team that sometimes dresses like me. But this is the team that really makes this do work. And if you see in the middle there's Tiziana in the middle. She's always in the middle of the action, I guess. And this is really what it's about. So I'm hoping that I'm going to be able to share some pros and points with you all as a team. I just want to make just a couple of little quick points. I gave a talk a few weeks ago about being from going good to great. I'm not going to repeat myself on this, but I want to make a couple of points, and then I'm going to finish, Milton, and we can talk about cases. I think I'm about 5 minutes over, but we're all moving from beginner to becoming competent to getting excellence. And I don't know if I'm excellent or not, but I'm striving toward excellence. And we have to think of ourselves at different stages. And when we do this, we have to just, first of all, just remember, like, what does it mean to be good, right? And I love the Martin Broadwell's work when he's talked about the 4 levels of competence, right? There's the unconscious incompetence. It means you're bad and you don't know you're bad. There's the conscious incompetence, which basically implies that you have to work on something, you're not that good at it, but you know what you have to do, and you know you're not that great at it. And then there's conscious competence. It means that you are good now. You have the skill, but you have to remember to do it. You got to go through the motions. You got to put effort into it. And then there's the unconscious competence, which is the ultimate level where you just do it, and you do it without even thinking about it, because it becomes automatic. Now, nothing's ever automatic, but it becomes second nature. And to get there, what I hope we will really strive toward is being curious, asking the right questions, digging deeper, and making no assumptions. I think these are critical when we're in our early learning phase. And in fact, I still apply this every day. Ask my fellows. When you move forward, we have to understand the basis of the skill we're trying to learn. We want to imagine, we want to visualize, we want to practice and repeat. All these things are very important to get there. And the learning curve will vary depending on us as individuals. But be prepared that the curve is not necessarily always going up, and it may go down as well, depending on where we are in that learning process. A lot of this, again, is about attitude and the will to learn and the will to do things. Training that attitude is so important. I love a lot of fun in the OR, I love a lot of good times. But for me, the approach and the attitude is very important. And I'm going to challenge you all here, and I'm going to say the majority of us here in the room are not necessarily bringing the right attitude to what we do. Because we think about learning things from skill, right? And we think that, as Milton said, that we have a natural ability, and the people who are great have great skill. And certainly skill means different things. Is skill just your motor hands? Is skill the ability to think? Is skill the ability to problem solve and use cognition? These are all questions. But it's not just, again, skill, it's also the attitude and the will. And so for those of you who have great attitude and great will, and you can do it, you have to just be trained. Those of you who may have good skill but don't have the attitude, you need to be coached. And so there's a combination of coaching and training that's very important with this approach here. And as we've seen from many around the world talking about behavioral, technical competence is only a very small part about doing great work. And everything else, the emotional intelligence, the coachability, the motivation, your temperament, are very important. So just think about that in terms of how we learn and how we do things, and think about where you fit on the scale here in terms of where you want to go with it. The other thing is, and just like with athletes, we all have a different way that we approach things and we learn, right? Whether you're conscientious, whether you approach things with steadiness, whether you're extroverted, or whether it's more of a dominance role that you play. These are all different ways. And I wanted to say basically that what's important to have, I hope, for all of you here, and that's why you're here, is a thirst for knowledge, to question, to ask why, to make no assumptions. And I love the whole unknown unknowns analogy here, where we think, of course, we know things, we make assumptions, and we have fake news out there, unknown knowns, and we question things that we need to question. But there are a lot of things we don't know, and we don't know those things. And it's the unknown unknowns which are important. Again, I just want to just add a couple of that.
Falar, porque o mais novo é tranquilo, o mais novo não tem nenhuma obrigação curricular. A minha preocupação nesse caso é o mais velho, né? Faz conta que eu...
Achieve the right competence. And I will stop here maybe at this point in time, and maybe, Milton, what we can do is, because I have a lot of slides, as you can see here, I can talk about a lot of different areas, about the attitude, about the cognitive part, and about the motor skills. But I think perhaps what the best thing to do maybe would be to start with some cases. What do you think, Milton? Should we start with some cases? Would that be good? Okay. All right. Fantastic. Good. All right. So let's start with this case here. And what this case is basically is a pediatric cataract. It's a patient who is a very young patient who is, I think in this case was about 2 years old, and you can see the central opacity here. So what I wanted to just pause for a second, and I know I can show lots of different cases, but this is the case that you may see in terms of what would be your approach. Now remember, when we talk about this, what I will often hear is, I'm going to do this, I'm going to do that. But rather than just only think about it this way, what really helps us to sort of approach these cases with the right mindset, what it is basically imagining and visualizing what has to be done, number one, and then problem solving and thinking, well, if this happens, what do I do next? And that means, of course, having different plans. So I don't know, Milton, I'll stop here. Maybe you got a team that's ready to go or to answer this question.
Yes,
Just try it out.
Yes, we have the first group of services with their fellows that they can bring their suggestions, their ideas of next steps, or ideas in which how to be prepared for such a case.
Who's our first group?
Ike,
Hello.
when do you implant IOL in the children? When?
Okay, so it's a question. So I mean, I think there's different, of course, attitudes on this. For me, I typically wait till about 2 years of age. That's been my kind of cutoff. I think very small eyes, I don't think do the best with IOLs, and of course, it brings up other refractive. Years of age.
Niño gritando.
Things we're going to think about in this case. And remember, it's a thinking exercise first. So someone's written down here. I can just see it. It says someone said PCCC, and the video is not running. Yes, I stopped the video on purpose because I want to hear what you all feel to make it interactive, and I will play the video for sure. So yes, I think a posterior capsular exercise I think is mandatory. And that's important because we know the issues around secondary visual axis opacification is going to be a significant problem postoperatively. So I do agree with that. Of course, that isn't always enough. And this is where, again, having the knowledge, of course, number one, that we know from studies this can happen, the implications of that we know, and we also know that if we do this right, that the outcomes can be very good. So we need to know that ahead of time. We need to know technically how to do this. Some of you have never done one. Well, what do? You speak to a mentor, you speak to someone who's done it, and you go and look at some good videos, which I think is the best way to learn these things. And number 4 in all this is always come in thinking about what's in your mind and what's in your hand. So what special instruments may I want to use here in this case? This will apply for all the cases, but I'm thinking right now, what will I need to do in this case that's going to be special? They'll be different. And I already have those ideas. So I don't know, Milton, do we have any suggestions on this? Quiet. We have some good questions, some good points that come up. I'm happy to just use the chat group and read the chat group if that works. We've seen careful hydrodissection. It may be something to consider. I think the anterior capsulotomy can be a problem. I agree with that potential challenge. So you want me to just go ahead, Milton? I don't know if anyone's going to answer, but that's okay. I'm happy to go ahead. And some people have written no hydrodissection. Well, I think that would be true if this was a posterior polar cataract, which doesn't happen to be one. So if there's not a posterior polar cataract, I like to do hydrodissection because hydrodissection is great to get mobility of the lens, but more importantly, can reduce some of the secondary cellular proliferation and PCO. But the anterior capsulotomy is a challenge. Number one, some people argue to do femto or not. Obviously, it's a challenge in pediatric population, and I would even question whether it's needed in general, just to put it as an aside, not to make too much commentary with. But a good manual capsular should be done. Now, how is it done well? Number one, I always use trypan blue, always, because trypan blue, in my opinion, and on the data, does reduce the elasticity of the capsule, and that's helpful for us when we have to deal with a very elastic capsule that wants to run out. Number two, make sure that you know the difference between shearing and tearing. And that's an important differentiation to make. Let me see if I can put up a slide on this one, because this will be very handy as we're doing a capsulorhexis to be able to switch between shearing techniques and stretching techniques. And that's important to differentiate it. And then thirdly, what I'm going to mention, let me find my slides here. Third I'm going to mention is the use of a super cohesive agent like Helon 5. I don't like to always mention trade names, but Helon 5 is a very, very powerful tool to use in these cases because it really helps to flatten the capsule. I don't have my schematic here, unfortunately, but I was going to show, here it is. I was going to just show a couple of points here to make with managing these difficult rexus. Let me just play the video here. So basically, remember the difference between shearing and stretching. You all know this, I'm sure, okay? But the difference between stretching, which is basically pulling things apart, versus shearing is very helpful and very important when it comes to dealing with these pediatric eyes that are very elastic. So you'll see, for example, in a case like this, where we have a capsular rexus that's running out, that you'll see that the use of a stretching technique is helpful. So here we're just doing the normal shearing approach. And as you'll see the rexus starts running out, the surgeon's going to turn the rexus back, flap the fold back. Well, not yet. Should have done it earlier, but they didn't. Now pull toward the center of the eye, or at least 90 degrees to the direction where you want it to go, and you saved it now. So that's a very useful tip for pediatric eyes. And for example, dealing with something like this, where you have a subluxed eye in a pediatric patient, you'll see that we're starting with a shearing approach here first. And then after this, as the rexus are starting to run out, we then convert it to stretching. So this is not only useful for a rexus that's running out, but it is very useful to redirect the rexus as you need to in a very elastic capsule. And look at the abrupt change in that trajectory of the capsular rexus as the rexus is starting to run out there. So it's a very useful tip to know. It's very useful to use this approach when we do the pediatric eyes. And I think what you've all mentioned here is all very valid in terms of what things to remember, what things to consider. So let's go back to the case, because we did talk about what do we do in these cases. And now I just lost my position here on my screen here. Where did it go here? Okay, well, I have lost it now. I can't believe I lost this. I lost the video here. But what I wanted to basically show was that, yes, I think a posterior rexus is very, very useful. I'm just going to put the video here. Pardon my my on the fly here approach. Milton, do you want to say anything, or did anybody want to mention anything while we're pulling this video out here?
Yes, the guys from group 1, they want to add some points.
Okay, please.
Ike, when do you use CTR in pediatric cases?
I don't think I really need to use it unless the zonules are weak. And if the zonules are weak, then certainly I will, but not routinely. Not routinely. I don't know if it really is needed, although one could argue, here it is, one could argue that certainly it may help reduce PCO. Okay, so here we have a rexus that's been done. I just have to forward it here. I typically do a regular hydrodelineation. Federico, thank you for looking at my slide and knowing which slide it was. That's pretty impressive. I use a chain cannula, which is a nice cannula to use to get under the rexus, and I do a nice both fluid and manual. Notice how I use my cannula to go around the capsular rexus capsule to free up some of that cortex. So both manual and fluid is helpful. I don't know whether anyone can remove the annotation there, but I can't clear it from mine. I don't know, Milton, if you can clear that annotation there. These are soft lenses, so we typically just use the IA tip to do this. It's a central lenticular opacity, lamellar opacity, and I generally like to come out of the eye by injecting viscoelastic first before coming out to prevent the collapse of the eye. These eyes are very elastic. The sclera is very elastic, and the eye can collapse and shallow very easily. I don't normally do capsule polishing, but this is a Singer sweeper by Epsilon. I think this is very useful in these pediatric eyes because they can get significant proliferation of the equatorial cells, resulting in phimosis and opacification. And so I just use this gentle, blunt edge to basically polish the undersurface of the anterior capsule. I think it's helpful in pseudofoliation eyes, helpful in pediatric eyes, and I think this is very useful to clear those cells out. You can see how many cells are removed with this. And I should have mentioned, by the way, the rexus, of course, always make it smaller than you'd like to in a pediatric eye because it's going to want to run out and it will stretch. Go for 4 millimeters and it'll end up being 5 millimeters easily. So I should have mentioned that. And this was the rexus that we got here. You can see how the capsule, how the epithelial cells have been removed here. The LECs have been removed. And at this point now, I'll put the eye well in the bag. Now, you all mentioned about posterior rexus, which is a good point. I do them routinely, of course, and I do them at least until the age of around 7, maybe 6, maybe 7 or 8. And what I do here, basically, I put the IOL in first in this case, and then I will use a 27 gauge needle, bevel down, filled with viscoelastic, a dispersive. I'll puncture the posterior capsule, and I'll inject viscoelastic right away into that burger space. A little bit already went in. Now I'm doing some more, just gently coating the area. I typically use dispersive. It can be annoying because the bubbles sometimes get in the way. And then I use a micro forceps. This is where I think having a special instrument like this is easier than a regular rexus forceps. A regular rexus forceps will want to gape the wound and shallow the chamber. And again, this is very similar to doing an anterior rexus, except we're working at a steeper angle and the capsule is very thin, right? 5 microns as opposed to 15 plus microns. And you can see that we're basically using the same shearing approach. Remember to make it small. Don't make it too big. 4 millimeters is fine. It does tear quite well, as you can see there. And you may have to convert to a stretching approach or the littlest technique to bring it in if needed. Now we have the anterior hyaloid space visualized. Do not shallow the chamber. Do not shallow the chamber. Vitreous can come forward. I do not do vitrectomies in these eyes. I was wondering whether someone would mention that. What I'm going to do is I'm going to optic capture the optic through the posterior rexus, what we call posterior optic buttonhole, POBH. And you can see the cat's eye appearance of the posterior capsule. The haptics are in the bag, not in the sulcus. I think it's better to put them in the bag so they don't cause any uvular irritation. And I do not go back and remove viscoelastic at the end of the case with my IA handpiece. This is my routine for complicated approaches. I routinely basically remove it manually to control the removal of viscoelastic and not have the chamber shallow. And that's a very common thing with all my complicated cases. That's what I do because I don't want to have things upended and vitreous coming forward, and I suture that wound as well and I inject some triamcinolone. So that's basically our approach to pediatric cases. This is just a capture through the posterior rexus, which is my preferred approach. And this prevents any cells from growing onto the anterior hyaloid and resolves it.
And we have also here, Ike, one of the guardian of the lens, which is Bruna Ventura. She has great experience with pediatric cases. So I invited her also to chime in. Bruna?
Hey,
yes,
Bruna,
hello.
how are you? She's
Hi,
one of the greatest guardians. Thank you for being here.
My pleasure, my pleasure. Beautiful surgery, Ike. Thank you so much for sharing and so wonderful tips. I usually operate these children starting at around 8 weeks of age, 10 weeks of age. And I also use a 3-piece IOL as you showed. So I usually have the routine of implanting CTR just because a 3-piece lens, even though I use the 5.5 millimeter of optic diameter, 12.5 millimeters from haptic to haptic, it's the smallest we have in Brazil, but still it causes a stretch in one of the meridians in a bag of a child this small. So the CTR avoids that beautifully. And I love the technique that you showed of optic capturing the lens in the posterior capsule. That's not the technique that I usually use, but as you said, I think you mentioned on Saturday with regards to other techniques that like you can solve the same problem differently. It really depends on the surgeon's preference and results. And I've seen many surgeons around the world doing what you described now, and it's a wonderful solution. I personally prefer doing the posterior capsulotomy and the anterior vitrectomy in these eyes. But beautiful surgery, and as many commented in the chat, wonderful images. I love them, and beautiful tips on how to make the rexes, which is a challenge in these pediatric eyes when the doctor is more used to operating on adult eyes.
Great, Bruno. Well, listen, you've got great experience. I think your tip about a CTR in a smaller bag is absolutely bang on. Of course, I typically put IOLs later on, so I think that probably minimizes it. By the way, what's your youngest age for an IOL? I should ask you that question.
8 to 10 weeks. That's when I start.
For an IOL?
For IOL, yeah.
Okay. Yeah, people are putting them in younger. I don't do a lot of those really small babies, to be honest with you, so I don't work in that level typically, but it's going to be good to see what the results are. So thank you for sharing that.
Thank you.
Good to see you.
Yeah.
We're going to do a sequel.
This is Fred Marcus. Can you hear me?
Fred. Hey, buddy. Yes.
Good to talk to you again. A nice surgery, and I'd like to ask a question. Why not doing the rhexis first before inserting the lens? Why do you prefer this technique? What are the advantages?
I think it was easy enough to do when the eye was in there, and just if there's a problem, the eye was already in the bag already. So I think it's just it's something just to add security. I've done it both. I've done it either way though. I think it just adds one more thing. Sometimes you put the eye well in, and I like 3-piece lenses in these pediatric eyes, even though 1-piece lens has less spring constant. It's just easier to do an optic capture. Or you can use a technique that Bruna showed really beautifully, which is to amputate the haptic nicely, as she showed on Saturday. But I just find it just very easy to do, as you saw, under the IOL, and it's already there. I don't have to worry about the tension going into the bag, potential of the chamber shallowing and vitreous coming around. It's already there. So that's my approach.
All right. Thank you so much.
Milton, I think you're the host. You may be able to clear the annotations. It doesn't bother me, but just in case anyone's wondering who's drawing on there, it's not me. I think it's Bruna.
Actually, Barbara, who is a fellow of us, she's the host. She's controlling the group. And
Barbara, if you go to the annotations on the menu bar, just click on it, and then you go clear all annotations. It'll clear them if you want.
Okay. Yes, I'm trying. Just a second.
Don't worry. It's no problem.
I will correct
just draw my face. It might be better than on the. Let's move to the next one, Milton. If that works for you.
Yes.
This is a posterior polar cataract, as you can see here. It's a little bit more than just a simple posterior polar. But I want to maybe, I don't know if you have another team who wants to talk about this.
Yes. Before you present this one, Victor.
Victor, yes.
Between the cases, he's bringing some insightful points for discussion. And
yes, you want me to pull up Victor's slides?
Yes, please. And Victor can interact as well, bringing up the points.
Okay, Victor.
Can you go to the last slide, like number 4?
4 or 5?
4, please.
I got you.
No, because I saw something like that.
I got you.
Yeah. In some situations, the iris can be very nasty. You can't control them. In a case like this, especially after angle closure, how do you deal with it?
Well, there are a lot of things here, of course, to think about, Victor. And thanks for sharing this case. We have a lot of interest in these cases, in these small eyes, which we may talk about. The first point, a couple of points. Number one, the nature of the iris may be more floppy in itself, but also the problem we have is we have a very shallow chamber that wants to prolapse. And these situations, I think, is very important to get a deep enough AC. And so typically I like to use preoperative mannitol and really soften the eye up to really make sure that the pressure in the eye is low. We dehydrate the vitreous to deepen the AC. That'll reduce the propensity for the iris to want to come forward. I think that's the first point, number one. Sometimes we do a pars plana tap, although I really am careful in a nanophthalmic eye because we don't know exactly where the retina insertion is, where the aura is. And this can sometimes be a problem. Sometimes the aura can be up to 2.5 millimeters from the limbus. So it may not be safe to go back and do a pars plana tap 4 millimeters back or 3.5 millimeters back or even 3. You can go more anterior and make a 2 millimeter entry to the pars or to the pars placata, but then potentially you may be hitting the lens. So that's potential a problem and a risk. So those are a couple of things I would add. Number 3, I certainly get them phenylephrine and mydriatics preoperatively, and intercameral can be used as well. I think it's important not to overfill the anterior chamber because that can risk prolapse, and we want to avoid this. And then I think if needed, an iris hook can be used, or multiple iris hooks, especially in the area temporally. If the iris wants to come and prolapse temporally or near the incision, putting an iris hook or 1 or 2 around or underneath the incision can be helpful to draw it away from the incision as well. So those are some of the approaches that can be used. I mean, certainly just with angle closure, the iris may be atrophic and friable already, and one has to be mindful of that. I don't typically use Malligan rings here because the space is very small. And if anything, I'll use iris hooks to expand the pupil if I need to do that in these cases. Those are some things, Victor, I would just throw in there as far as handling this. And then the other thing is before coming out of the eye, we never irrigate. So we're always at position 0 and stop. We maybe inject viscoelastic in the anterior chamber just to keep the chamber formed. Don't do too much though. And then slowly pull back, very slowly to keep the eye formed. Those are some things I would just add in there.
Okay, and sometimes after you do the cataract surgery, the iris just stays like there. When do you do the cerclage? You have like a special technique of doing it? When
I do like cerclage, and I do them in these difficult angle closure cases as well. I will often do it at the time of surgery, although I will say that, you know, if you're struggling for the case and you want to just get out of there and you have positive pressure, then maybe you should wait and not do it. You can always wait to do it later. Sometime, of course, the pupil function can return somewhat, but usually in angle closure, it doesn't. There's another reason to do this, which may not be evident. Of course, we reduce the photophobia, and I try to bring it down to 3.5 millimeters, and that can be a good thing for the patient. But the other good thing it does is it keeps the angle open, okay? So therefore, it draws the iris away from the angle and prevents resynechia from forming, which happens when these patients, when the angle closure, phaco, and they get PAS again if you've released it. And keeping it on stretch with a suture or pylo, but suture is effective, can also help to prevent that as well.
Okay, perfect. And if you have like afterwards a video to show us, would be awesome, just to see your technique.
Yeah, I can do that. Do you want me to show it now?
It's up to you.
Yeah, sure. I can show it now. Let me show you a case here, which I mean, I do pupillar cerclages a lot, but this is a very interesting case, and I want to just bring it here because it's basically follows along your example, okay? Because this is and I'm going to maybe deviate a little bit, so be prepared, the audience, to answer this question here. And remember what Victor's point was, what he was asking about. This is the initial presentation of a patient. High pressures, the chamber is shallow, the angle is closed, pressures are 50, but it's not acute. It's not acute. It's chronic. Pressure is 50, the cornea is clear. On all the medications, they're on 25 and 29, okay? So then you can see that the nerve is not terribly damaged. There's some pericentral defects that may or may not be from the glaucoma itself, or maybe from ischemia or other causes. The glaucoma certainly is not severe. The initial surgery was done. Hey guys, I'm just on a conference, guys. Sorry, it's loud in my house. I apologize. Initial surgery is done, and phaco is done very uneventfully. The post-op pressures are 15 to 20, and the glaucoma medications are tapered off, and pilocarpine stopped. Now, 6 months later, the patient comes back. They come back, and the pressure is really high, despite phaco being done. They have a deep AC, but they have synechia everywhere. So you may be thinking, is this malignant glaucoma? Is this open angle mechanism? Is something else causing the angle to be closed? Well, basically, they have synechia formation again. And on all the medications and Diamox, the pressure is now okay. So you can see on the imaging here that the chamber is very deep, the eye wall sitting back. So we should all be thinking about malignant glaucoma here, or thinking about something pushing the angle closed, but it's not in this case. But you see that the angle is closed with synechia and the pupil is small. Okay, so I don't know, maybe I'm going to throw it back to you guys. Maybe Victor, you're here too. How would you handle this case? Remember, they're on Diamox and the pressure is better, but they can't take the Diamox. Off the Diamox, the pressure is up 25 to 30. Any thoughts about how would you manage this case with recurrent PAS after phaco? So phaco doesn't always solve the problem. Any thoughts how you manage this? Or anybody?
I would say cerclage.
Damn, you got it. You got it. It's a great plan. I love this plan. Let me show you what we do here. We're doing a cerclage though here, Victor, not because of a small pupil.
Okay.
Not because of small pupil. We're doing it for functional angle opening reasons. Now look at the angle, it's closed. I think it's very nice to have an intraoperative gonium mirror in these cases. And you can see that the angle is closed. And what we're going to do is we're going to do goniosynechia lysis. I think it's important. I wrote an editorial in Ophthalmology Glaucoma about GSL and the role of GSL. I do believe when the angles are closed more than 4 o'clock hours, we should be doing GSL to make sure it stays open if they're not open after phaco. And under direct visualization, it's nice to have a gonium mirror to release the PAS with a pair of forceps. So there you see that angle is open now. Look at that. You see some reflux of blood in the canal of thumb. Fantastic, fantastic. Okay, so here's a situation where I'll give you a story. Basically, this is a paracentral peripheral iris cerclage. Just watch me do it. I'm using my left hand. I'm using my right hand. I'm using microforceps. I'm using needles. But what I want to tell you more is this. How did this idea come about? Well, it came about because exactly what Victor said. He said, well, when I had angle closure cases and I had an ton of people, I would do cerclage on those patients. And one of the most important things of an astute clinician is to be a really good observer. Observation is important. And when I was small, I used to always pick out little small things that other people didn't want to see. Sometimes it was annoying people. But I picked out and I observed that my patients who had pupil cerclage after angle closure glaucoma, they did the best. They did the best. They had no medications, pressures are controlled, and they did very well for the most part. On the other hand, those that had a floppy iris or had, atonic pupils, they sometimes got restenochia formation. So we said, well, listen, this is a great case to do a cerclage, but the patient doesn't need a small pupil. I don't want to make the pupil small. It's functioning still, but I want to make the peripheral iris on stretch. So instead, we're taking multiple bites, maybe 3 bites only per quadrant, going around up and down like a basting suture and coming out through all quadrants. Once we come out of the eye, we basically will tie it. I use what we call the Ike Ahmed technique, McCannell and Ahmed kind of working together here to use it, using microforceps to tie the suture outside the eye and bring it into the eye. You see how I'm looping it outside the eye and I'm sliding it into the eye. I'm putting tension on that suture because what we want to do, you can see here when I inflate the eye, look at the chamber deepen up, look at the pupil expands, but the peripheral iris is still on stretch. And you can see the pupil stretch there. The angle is nicely open, and there's the view of the patient post-operatively. Look at the suture all the way around. The pupil's still functioning fine though, which is fine. But look at the OCT, the UBM. The pupil functioning is fine, but the pupil's on stretch. That's why it looks very thin, and the angle's open. So I just want to share that example. It would be very similar, Victor, for a case of someone who had an atonic pupil, except my bites would be closer to the pupil margin. It'd be more like a classic cerclage, which we've described many times. Which, just to go through here for an example here, we would be doing it more to the pupil edge, like this, the same technique, and then bringing it down, and basically suturing it. So that's a long answer to your question, Victor. Sorry.
Thank you. And just another question here: do you bend the needle, or it comes like that?
This particular one, it's a CIF4 needle. There you go, and it comes on a curve. You can see it's a quarter arc curve, quarter circle, and you can see it's a nice long taper cut needle, which is my preference.
Perfect. Thank you.
Excuse me, Ike?
Hey, Isabella.
Yeah, I am a resident from Ipsendi. Just a question about this case.
We go way back. Come on.
How often do you get hyphema after a pupillary cerclage? An iris?
It's very rare. It's very rare, actually. Surprisingly, it's very rare. I mean, hemorrhage occurs when we pull on the iris root.
Okay.
If we pull through on the iris, it can cause a hemorrhage for sure. But simply passing a needle through the iris, unless they have neovascular glaucoma or NVI, it just hasn't happened. The microvasculature is so small in the iris, it doesn't seem to be a problem.
Okay, thank you.
Someone asked a question about why not do YAG laser peripheral iridoplasty. Well, the number one, it wouldn't be enough, of course, because it's PAS, so I have to go to the OR anyways. And number two, yes, that is an option to do iridoplasty for sure. And if you're not in the OR, you can try that, but that isn't always successful. I find my results with iridoplasty to be variable, and it can sometimes cause reoccurrence to PAS. So yes, I do iridoplasty, but in a case like this where I'm going back in the OR to do synechialysis, I said, why not do the cerclage? And I am doing this under local anesthesia with topical lidocaine, topical tetracaine intracameral lidocaine.
Dr. Ike.
Hello.
Hi, my name is Deborah. I'm a fellow.
Deborah. How are you?
Fine, great.
How's it going during COVID? Are you working?
In a little bit, just urgence. Yes. But someone asking you about the anesthesia, so I want to ask you about the anesthesia too. Do you do some dilutions of adrenaline or epinephrine in lidocaine, or just lidocaine using anterior chamber?
No, for me, I basically just use intracameral lidocaine, 1% methylparaben free, so we don't have any preservative in it. I will use some phenylephrine if I'm concerned about floppy iris or the pupils dilating. I think phenylephrine is fine. I just take phenylephrine 2.5% minimum. We drop, 4 or 5 drops in the 1 cc, 3 cc syringe, and that's it.
Okay, and another in just this case or all above the cataract surgeries?
No, cataract surgery, I don't use anything in the eye, not routinely.
Okay. Just topical anesthesia.
Just topical, yeah.
Okay,
I know
and
it surprises some people, but I don't typically use it.
because some patients have, I don't know, they feel the products, some preceptor told us to put the lidocaine intracameral.
Yeah, so I'll make a couple of comments on that one. There've been some studies, and the studies kind of show that perhaps it may or may not help. I think it probably depends on the eye. And the other thing I'm going to tell you is one thing, okay? Here's one thing I'm going to tell you, and your preceptors are going to hate me. They're going to hate me after I say this, right? But when someone tells you, do it because we've always done it this way, or do it because it's a good idea, I want you in your head, at least, all of you, to say why. To say why. Right? Challenge yourself. Even if it makes sense, of course, lidocaine, of course it's going to be better. Just be contrarian, be skeptical always. Don't be rude. Don't be what the hell you're talking about. Ask yourself, go do some research, and then come back with the answer. And ask other people, right? Luca makes a good point. We have seen TAS syndrome occurring from injecting anything extra in the eye. So if you don't need it, why do it? I can be honest with you. I've done even pupil repairs without lidocaine in the eye, believe it or not.
Yeah.
So when it comes to anesthesia, it's very subjective. And we always remember the patient who had a problem, but maybe they would have a problem anyways. I don't know. I would also say it depends on the patient. It depends on your population. It depends on you as a surgeon. I don't want to be cavalier and say, oh, for sure, you never need it. But I can just tell you my own personal experience.
Okay, thank you.
Thank you for the question. Sorry for the philosophy again.
No, it's perfect for us.
Now your preceptor is going to hate me. He's going to say, oh, this guy, never invite him again. Someone mentioned about iridotomy. Well, this is not malignant glaucoma. So I don't think we need to do a iridectomy or a zonulectomy or capsulectomy or hyalodectomy. I would for sure if it's malignant glaucoma for sure, but not in this case. All right, so Victor, I hope I took the opportunity to answer your question here. And by the way, Milton, this webinar is for 5 hours, right?
Yeah, we have up until we have 3 hours from beginning to end. So
all right, well, it's going by fast, everybody.
Good.
Should I move along then?
Yes, please.
Okay. Well, I have lots of things to share. I just trying to think what would be useful. I want to make things practical as well, and maybe we can just touch on posterior polar cataracts. I'm sure you all have had these cases here. And by the way, Alejandra, thank you for asking the question. Iris cerclage is beautiful in plateau iris, which is actually, I should have mentioned, was the problem in that case I showed you. The case I showed, the problem was, I should have mentioned it, the problem was a plateau situation. And that's why, even though the lens is out, the chamber is deep. If you look at the ciliary process here, we see the ciliary process has a very high insertion, and the pupils and the iris is inserting anteriorly, causing angle closure. So yes, thank you, Alejandra. It is exactly the situation like this where we use it, and that was the situation in plateau iris. So great point. You're welcome. Where are you from, Alejandro? Alejandro Sosa. Who knows where Alejandro Sosa is from? Guatemala. Oh, Guatemala. Nice. Okay, never been to Guatemala. And Tiziana has just mentioned, yes, sorry, 23 gauge micro tying forcep. Yes, from MST. That's the one we use. But I mean, really many different ones can be used as well. I see someone said Ramadan Mubarak. Yes, it's Ramadan for me. I do fast. For those of you who are wondering, I'm not eating or drinking anything or smoking during the days from 4 in the morning till about 8 o'clock or something. But that's what I do anyways normally. Okay, so Milton, should we go to our next case here? Does anybody want to give me some input on the posterior polar situation here? Maybe maybe you can see something extra going on here that may worry you.
Posterior capsule deficiency.
Yes, so this is this is going to be a concern. Posterior capsule may be deficient, and the cataract here we're seeing is a posterior polar, right? So what are you going to do as far as your surgical approach here? Or let me ask it a different way. What's the concern in doing the surgery here? Gustavo, pick somebody. Everybody's quiet. I hear crickets or hissing sounds. Camilla, where's Camilla? Camilla Sawatani.
Hi.
Hi, sorry to pick on you. Tell us who you are.
I am from Brazil, from Campinas.
Okay, oh, from Campinas. That's where I know many people from there, yes. So,
yes.
You can answer my question, but don't read the chat group. It's giving me the answers. And Lucas Torres asked a really good question as well. I will have to answer that maybe later on, but endocyclophotic coagulation. Yes, ECP can be used. ECP, to laser the ciliary processes, is a technique I developed many years ago to do this technique as well, which is another option too. Yes. So yes, Camilla, I think you were going to say. Are you going to say anything, or am I going to go ahead?
Hydrodissection.
Yes, I think that's, for me, it's the number one pearl. That's the only thing I want to mention, is don't do hydrodissection. Do a good delineation, even though an aggressive delineation, though, can cause excessive pressure in the bag and cause the capsule to rupture. And so we have to be very mindful of this. It's also important to do a good rhexis that's going to be centered and about 5 millimeters, because we may have to do optic capture here, right? So that goes fine. Let me just move to the hydro. I do a little bit of manual disruption of the cortex. Watch what I'm doing here. I'm not injecting, I'm just lifting up and I'm just moving the cannula. Why? Because I don't want to fight with the cortex. But by doing a manual dissection, not by hydro, but manual, which, by the way, I do routinely even when I do hydro dissection, it just roughens up the cortex and allows me to make it easier to remove. And then with hydrodelineation, we want to basically go to the mid-periphery, 45-degree angle into the lens substance. It's better to err on the side of making it too central than going too in the peripheral. And we may want to do multiple lamellar dissections, delineations. Remove the central endonucleus. This is my same technique for soft lenses. Anybody's having trouble with soft lenses, I guarantee you, if you do hydrodelineation every time, you'll never have a problem. This is what I found in my example, because it really helps to separate the endonucleus from the epinucleus. You can see, though, we have a concern here. We have a central round phimotic opening there that we're not sure whether there's anything open, but you can see some small fragments behind that opening. So we inject more viscoelastic, which is helpful. I'd have to trim the epinucleus in the peripheral capsule, and then we remove the central at the very end by flipping it up. And never, ever, everyone has to remember, please learn how to inject viscoelastic with your other hand when you come out of the eye in complex eyes. Start routinely, always start routinely, but then do it. This is such a great tip to avoid complications like vitreous prolapse or even choroidal expansion. You can see I'm playing around there. I do see some problem there potentially, but I'm going to put an IOL in. And I think it was Federico who did ask that when do you do a rhexis? Well, here again, I'm showing you, I'm putting the IOL in the bag now because I know I'll have the IOL in the bag now. So when I do my work, if something goes wrong, it's already there. And I put the IOL, it's not going to cause traction on the capsule. But look, that's a phimotic capsule. I should stop here. I should have stopped here and said, what are you guys going to do? I should have mentioned, by the way, this is a young, I think this patient was about 4 or 5 years old. So you can see that there's a phimotic ring on the posterior capsule, which is open. So Milton, I don't know, I'm going to stop here. I gave a bit of a tip. What will people do here? Federico said vitrectomy. Okay, that certainly is an option. Yes, vitrectomy would be a very good consideration here.
Aline is also here, and she wanted to add something. Please, Aline, you can go.
I have a question from before this step.
Too bad. I'm kidding. Go ahead.
I saw that you did a sort of hydraulic section, but you did only the anterior part, not going to the posterior capsular. Is that right?
Let me just tell you something. I didn't do hydro. What I was doing was I took my cannula and I didn't inject. It looks like I'm injecting, but I'm not. What you see, basically, I'm just moving it on the capsule manually.
Oh.
Okay.
Manually. How you say in Portuguese? Manually.
Manualmente.
Manualmente.
Yes.
So I'm doing a manualmente technique where I just using it to just free up the cortex. Manualmente. Obrigados. Obrigado.
Okay, thank you.
Regarding to this step, may I ask a question about your thoughts about? We always learn about not hydrodissection, hydrodissecting these cases. For my surprise, Barrett does always hydrodissection in these cases after hydrodelineation. And I saw a talk, and we talked in a meeting, and he never have any posterior capsule rupture following this procedure. Have you heard about this, or have you seen this?
So this is a great point, because all of us here are going to hear multiple opinions.
Yes.
And no one, not necessarily wrong, but when you have multiple ways to do something, right? Do you do optic capture for pediatric or do vitrectomy? Do you do lidocaine or not? What we have to do is understand the physics of what we're trying to achieve here. So we have to go on a physics basis or theoretical basis or evidence basis to show. Now, there's no randomized study showing hydrodissection versus no hydrodissection by the same surgeons to prove one or the other. When you don't have evidence, you have to go to the theory and you have to go to the basic science and the physics. And the only thing I will say is that when we talk about physics, we do know, and we've certainly seen cases where hydrodissection can blow out the posterior capsule. That is something that we don't argue with, and we've seen it even with femto, for example. So it can happen, and we know that posterior polar cataracts have a thinner capsule and may be open, and so theoretically, there's certainly a risk. So when I have this debate, for me, I look to the theory. And then the last point is, what is the harm in skipping the step? What are we losing? What problem are we creating by not doing hydrodissection? To me, honestly, hydrodissection is a bit overrated. We can do phaco with a hydrodissection. We could. Of course, we may have a bit more time getting the cortex out, and maybe there's more PCO, but we can do that. So for me, I compromise. I do a little bit of manual separation with the cannula, and I do not do hydrodissection, because for me, for those reasons, the benefit risk here, I think, is outweighed by the risk of having a posterior capsule opening larger. That's my answer.
All right, thank you.
Yeah, and it's so interesting that you question every single step. Every
single step we question. I hope that's kind of coming clear to everybody, because
why not? Why not?
Why not? Exactly. And you know what? The answer may not be from your preceptor or by your colleague. The answer may be now, there's no excuse. You can go to Google and find out. You can go to internet and find out. And you can go to meetings and talk to other colleagues to find out. But if Ike Ahmed says, do it because this is the best way to do it, then you should say bullshit.
Yeah.
You should say bullshit.
Yeah.
And by the way, I want to mention that I'm here teaching here, but there are great people on this call that have great pearls to add on this one. So, you know, I'm in no position to say this is necessarily better, but I'm telling you my philosophy on it.
Ike, hello. This is Andre Berger again.
Hey, Andre, how you doing?
Fine, thank you.
When I say Andre Berger, I lower my voice. I go, hey, Andre, how you doing?
Yeah.
How you doing, Andre?
Let me ask, I know you are a very good posterior surgeon too. In this case, can you think about start with a posterior vitrectomy to avoid anything? For example, this case, you have a roll before, you have a tear in the capsule before you start the surgery maybe, or you think it's going to happen anyway. Can you do that? You do that anyway, or you simply don't do it only if you want, only if you need it?
I think it's a very good judgment call. For me, I combine my comfort level, my experience level, and my theoretical concerns into making my decision here. For example, I do parspline incisions all the time and vitrectomy all the time for dislocated IOLs because I know that vitreous is entangled in the IOL, for example. But here, it's a young patient, number one. The anterior hyaloid is likely to be intact and formed. And with the right surgical techniques and variations, I feel I have a very good confidence I can do it without vitrectomy. And of course, if I don't have to do vitrectomy, I think it's a much better approach than having to do more vitrectomy. But I think those are the factors I use to tell me I don't need to do it.
All right. Thank you.
So I think, so what I'm doing here is I'm still trying to avoid a vitrectomy. So I'm going to make a little cut because what happened here is the posterior capsule opening is thick, it's thickened. These are hyaloid artery remnants here. And so this isn't posterior polar cataract where it's just a small opacity. You can see it's a thickened round circle. So what I'm doing is I'm doing a posterior rexus. I figure, you know what? If I can do a posterior rexus, I can remove the opacity and I'm going to be fine now. This is a young patient. And yes, I'm using glasses for sure to make sure that I keep the hyaloid back. So we do the posterior rexus. And you can see by doing it, I've removed, it's a nice circle. I love doing posterior rexus. Our fellows and residents do them. And what you see, what's remaining though, is there still are these small dot opacities, circular opacities present. And they're actually on the anterior hyaloid. And again, I could do vitrectomy, yes, but once I break the anterior hyaloid, I set off a whole series of potential risks and inflammation and blood visual disruption, everything else. So what I'm doing here now is very carefully, I'm irrigating and aspirating and vacuuming these opacities off the anterior hyaloid, right? Now, I've never done this in my life before. And my point to you is this, that there are going to be many things you've never done in your life before. And of course, I could be going to the basic thing and say, I need to do vitrectomy and this is all I'm going to do. But again, number one, knowing how to do the 27 gauge cannula, number one, is important. Number two, keeping the anterior hyaloid formed and respecting anatomy is an important principle. And look at the difference. And number three, being very gentle and minimizing harm and having experienced vacuuming the posterior capsule with the cannula, which I've done before, I've managed to clear that opacity off the anterior hyaloid without disrupting anterior hyaloid. And then I'm doing optic capture. This is my standard approach again, because there's no place for the lens epithelial cells to migrate over the hyaloid because the IOL is there now. So this is of course a little bit of a variation in a regular posterior polar cataract, but I wanted to show you, this is literally innovation in action. I'm not making a big deal about it, but this is literally problem solving on the table, saying I didn't expect there to have these little opacity on the anterior hyaloid. How am I going to remove them, or am I going to leave it? And going back to having, that logic and experience, of course, to be able to do it because of my experience using the same technique to vacuum off cells from the posterior capsule. So I want to share that approach.
Yeah, again, we have Bruna Ventura. She has a great experience with radio frequency for posterior capsule. And it's so interesting because I don't know, why is it not a trend in terms of a device that we use routinely? What are the cons of radio frequency? And
radio frequency has been used by many people. I think it can be very successful. And I guess you're asking why did it not more popularized? I guess.
Yes.
Yeah. I mean, I think there might be different reasons. I can tell you that just on the studies, and Bruna probably can maybe answer this question because I don't do radio frequency. I've just seen some reports and studies. Nothing is stronger than a curvilinear tear, right? That's the best.
Yes,
a femto isn't necessarily as strong. Radio frequency is not bad, but it's still not a perfectly torn rexus edge. So
one question, why wouldn't you wait to do a YAG laser afterwards in this patient?
Great question. And I think that's a really good point to mention. If it's, of course, a small opacity, for sure, leave it. But this wasn't a small opacity. This was a thick donut of an annular, thick, white opacity in a young 5-year-old patient. And if I just yagged it, I think it's going to basically end up still being present there. So that's why I went for it.
Yeah.
Thank you for mentioning that. Yes, for sure.
Yeah, with regards to the radio frequency cautery, it's very interesting what Milton asked. Especially in cases where the fibrosis is very thick and where you need to, because sometimes, as you showed, you could do your rexus with the forceps just around around the fibrosis, let's say it that way. But sometimes you have a very big block of fibrosis, especially in the pediatric population. And it's interesting how the radiofrequency cautery is able to do the rhexis, where otherwise probably even the vitrector in some of these cases have difficulties doing it. But I agree with you, if you can use, let's say it's a capsule that you can use your Utrata or another forceps to do, and not use the radiofrequency cautery or let's say the vitrector, that's number one. But sometimes you really have to think out of the box, as you showed here, your first case aspirating the opacities, and sometimes it does really help having this device for sure. But one thing that I have to mention is that when we use the radiofrequency cautery, it's very unlikely that we won't compromise the anterior vitreous. So usually when we use the radiofrequency cautery, you already know that you're going to end up doing the vitrectomy, the anterior vitrectomy.
Yeah, no, I think that's a great pearl. You muted yourself just on time, it looks like. Yeah, and I think those plaques are difficult. I mean, what I've done in some of those cases is use a femto laser to actually femto. That's one application of femto to cut through a plaque. But I think those you have to use something. I think that's where radiofrequency or a fugal blade or something is very useful. So thanks for that comment.
Can I ask you a question?
Yes.
We are having some questions here in the chat, and they are asking about opacification and when do you polish it? When do you opt for polishing the posterior and the anterior capsule in general?
Yeah, I mean, in general, I don't do it routinely. I think anterior capsule polishing sometimes can result in more PCO potentially, believe it or not, based on at least a couple of studies, one of them randomized. And I don't find I need it. But I think in the pediatric population, I think it's a good idea because I think these patients do get more potential proliferation on the anterior capsule. I think for pseudoexfoliation, it's not a bad idea. For loose zonules, those kind of cases, it's not a bad idea. But I have to say, I don't do it routinely. Just in the pediatric population, I just mentioned that.
Thank you. Should we go for one of the other questions? You just put the slide here.
Yeah, sure. There was a question about CME opening the posterior capsule. So I think yes. I think Lucan probably makes the point here that if you don't open the anterior hyaloid, if you don't touch the anterior hyaloid, you simply just open the posterior capsule and do whatever you have to do. There's less theoretical risk of CME. And I think that's a benefit in leaving the anterior hyaloid intact. David Murphy from Arkansas asked about delamination, about gentle viscodissection. So I think that can be tried. I mean, the challenge is if you're doing it before the cataract's removed, you have to go under the anterior capsule, and then you have to get the viscoelastic to go behind the lens. And in that process, we increase the intercapsular pressure, and there may be a risk of having more pressure that can cause it to become larger. So that's one of the concerns, although again, that's another technique that's been described, viscodissection. But certainly once I start removing the lens material, as you saw in the case, I will inject viscoelastic during the surgery though, for sure, to help to cover that area.
Sure.
I see.
Dr. Ike?
Yes, I see Larissa.
Yes, it's me.
What's up, man? Hey, I like your background. It's like my background.
Thank you. It's my library. I would like to ask you a question about this case. Is there a risk to retinal detachment by cleaning the anterior hyaloid or no?
I believe the answer is no, and the reason why is because I'm just polishing it. I'm not actually pulling it. I'm not removing it. I'm not cutting it.
All right.
So I think the traction risk of an RD I think is less. Now, of course, in general, any surgery can risk retinal detachment, but I don't think it's higher than it would be if I'd left it alone.
All right.
It's my opinion.
Thank you.
Hi.
Mateus.
Dr. Mike.
Mateus.
Yeah.
What's up, man?
Hi. I have a question here. In this last case you showed us, do you used to ask for some extra exam before the surgery, like OCT or UBM, just to confirm that you are dealing with a truly posterior cataract?
I have lots of images that I've done with OCT particularly, because the discrimination with OCT is excellent. But I guess the point is, it doesn't change my management. I'm still going to approach this case like the castle may be open, because if it's not open, it's still very thin. And so I don't find it really makes a difference, of course, and I have clinical examination to show me and to examine the posterior capsule already. So, but yeah, I think it's a great adjunct. It's nice to have it. It doesn't change my management? Not really, to be honest with you. In personal.
Mm-hmm. Thank you.
And I think Ori asked about using hydrogest to clean it. That's exactly what I did, Ori. I actually injected BSS, and then I aspirated a little bit too. So I did both, a bit of injection and also a little bit of polishing. So hydro, yes, this hydro as well as polish. Both techniques are used, exactly. All right. Well, should we move on then?
Just one last question, Ike.
Yes, sir.
Did you use triamcinolone to make sure there's no vitreal prolapse, or just by looking you?
So the problem with triamcinolone is that if I inject it right now, I have the eye filled with viscoelastic, right? I mean, I have viscoelastic in there the whole time. And so if I do that, then now I have triamcinolone in my viscoelastic. So it's going to be very hard to differentiate vitreous from viscoelastic. And then I have to go do vitrectomy. And now for sure, if I do vitrectomy now, I'm going to get vitreous coming forward. So as you saw this whole case, the chamber never shallowed. I did my posterior rexus, vitreous is still, anterior hyalo is still there. And you can see right now, look at my cannula. My cannula, I'm literally injecting, and you can see I'm just basically polishing the anterior hyaloid. And you can actually see the anterior hyaloid at some point, touching there. So I know that's the anterior hyaloid.
Okay, thank you.
Thank you. Okay, Milton, where should we go to next? I think Victor, you had a case to show here.
Yeah, sure.
Where's my man Victor?
Well, this is like a continuation. Yeah, this is like a continuation of the previous one. When you have like a traumatic cataract like this, and that happens to the iris, how do you deal with it, with the cataract and with the iris?
It's a great question. I'm going to show you this case here, which is kind of similar to that. And by the way, I want to mention Victor. Victor is a very kind man. Because when I was in Brazil at the meeting at the Brascars and even the glaucoma meeting, Brazilian glaucoma meeting, CBG, man, he was so kind to me, and I appreciate it. Very gentle, always kind of helping me out. Always asking if I need something. Always kind. So I want to just thank you for that. It's a great Brazilian hospitality which you showed me. So thank you. And I see you always. You're always smiling. We always give each other a big hug, which unfortunately with COVID we can't. So you can see this case here. This patient has multiple problems. So whenever this is in the clinic now, I don't know if Milton, if you want to have a resident or fellow speak to this problem, but I usually ask somebody like, what are the 5 different things we have to think about here that's special, and what are 5 things we want to have in our hand that we don't normally have in the OR, right? I mean, that's the mental approach to thinking about this in this case.
Yeah, it's a very good questions for our fellows and residents. It's a very interesting one. So I'm waiting for them to chime in.
Victor, everybody's writing on the chat line that it's not true. What I said about you is not true. I said you're not a gentleman. You're not very nice. I don't know, man. You must really piss off some people there.
But I have to say, I'm a big fan of yours. Since I'm
a big fan of you, my friend. I'm a big fan of you, buddy. Mutual admiration then. So maybe while people are thinking about this, Milton, let me give you a couple little pearls. What I like to say is about excellence in different ways. When we think about excellence, we think about it in different ways, right? We have better outcomes. We do it more efficiently. We do it safer, and we may do it so we're more satisfied. And Ivo Ferreira, who we collaborated on this project about training, I think really nicely divided up the way we learn. Mindset, cognitive skills, and motor skills. And I remember on a call I had with Milton and the group yesterday, we talked about people's learning curves. And somebody asked, well, everyone has a different learning curve. How do you teach people with different learning curves? And I think it's a very good point. First of all, I think the learning curve will vary between people, of course, it's understandable, but the learning curve can be broken down into these three components, right? Usually we think about the motor skill. We think about, I'm going to teach the surgeon how to suture iris. And we go right to that suturing technique. And that's fine for motor skills. You got to work on that. But we often neglect the cognitive and the mindset skills. I can tell you, even across Canada, most residents are not taught the mindset and cognitive skills. And if there's one tip I want to give everybody here to please stop, and this is for any surgeon, including Milton and Victor and everyone else here, Andre, Gustavo, all the people that are here and others, is stop and think of yourself in three ways. Milton's learning curve may be very short on mindset, but may be very long on motor skills. Sorry, Milton. On the other hand, Victor may have a very short motor skills learning curve, but very long cognitive skills learning curve. So you have to know your own weakness. A teacher like me has to know your own weakness as well, and has to be able to develop your skills in one of the three areas or more, or four or three of them. And that's important as we think about moving into that direction. So please remember that
may I chime in?
approach. Yes.
Back to your slide. I love this topic. And, for our Brazilian and Latin American guys who they either identify one local idol as a very skillful guy, which was Ayrton Senna. He was a top Formula One driver.
Yes.
And if you go, I love Formula One myself, and I see the pilots as very high performance athletes. And it's so interesting that when you don't see them, when you don't know them, and you just watch Formula One races, you don't know the extreme high-end athletes they are. For example, Ayrton Senna was a very thin guy. He exercises so much, he got into an athlete body. On the other hand, he practiced meditation. And it's so interesting that if you think of a guy who goes to high racing sports, but on the other hand, training his mind to be as silent and present as well. And so, on the other hand, cognitive skills. Well, he was known by the king of the rain. He drove in rain as he was in dry. Excuse me. But what people don't know is that when he was very young, he was very bad in wet situations, and he practiced every time it rained. He took his go-kart and practiced in wet, so to overcome his limitations. So I think you're absolutely right in segmenting these three aspects.
Yeah, I think that's kind of an approach to make, and I can tell you that, like we said before, I mean, 15% maybe is technical ability. All of you here that are watching and thinking about doing these cases, or even learning basic phaco, I guarantee you that 80-90% of you can do this, right? Can do these cases, but it's got to take the mindset and the cognitive skills, which are really important. So while you're here waiting during COVID, look at these kind of cases and walk through them. I saw a beautiful answer by Anna Sylvia Serrano. I have no idea who she is. Sounds like she's smart. I don't know. I have no idea who she is. Probably a little bit smart, maybe not. Maybe a little bit difficult to work with as well. I don't know. I'm just kidding. But she gave a very nice answer, right? I mean, she's thought about this. She's thought through it. And she's watched videos. She probably listened to everything I say. She believes everything I say. And you know what? She's well prepared, man. I mean, I can guarantee you, if she was with me and doing that surgery, I would feel very comfortable that she'd be able to handle it, because she's prepared. She's thinking about it. She's written it out. Even myself, believe it or not, I mean, I will always be sitting down in my chair at home and thinking through things. and imagining in my mind. I'm a big, I have a huge imagination. Sometimes it's dangerous. And I'm always thinking and visualizing what I'm going to do. And I'm drawing things out, exactly where my incisions are going to be, my sutures and everything else. And we're planning this out really well. And I find sometimes it's hard to teach the fellows this. It is hard to teach them this part of it. But when they do this enough, what happens is you get to a position where you can actually see the unseen. You actually can see things without actually seeing them. And I know it's because I test the fellows at the end of the fellowship. I cover their head, and they have to walk around the OR. And if they touch anything, then they don't pass. You know what? They all pass. We'll see what happens to Tiziana this year, but they all pass. So yeah, come to the OR prepared. And Keith Liang, my man Keith here, Keith from Sacramento. Keith is a great surgeon and a great friend. I always bump into him at meetings. I want to mention that, you know, what I really miss about these meetings, what I miss about not going to meetings is exactly this. Seeing someone like Keith and I, for some reason, we never plan to meet. It's my fault usually. And I always bump into him as I'm walking from one hotel to the next or running from one course to the next. And this is the beauty of these meetings that we don't get by this example. That's what I really miss the most. Not education, but I miss these little unique opportunities. And with Keith, we talked for 2 minutes and we're both running in different directions. But man, that's humanity right there. So Keith, good to see you. Sorry about that. I have tangential thinking a lot. Anyways, this is basically what we have to be thinking about. Walk into the OR prepared, just like walking into a hockey game or a football game or a soccer game, being ready to do everything you got to do. All right. So I've been lecturing everybody now. Are you guys bored?
No, it's great. Absolutely great.
So, listen, I know that we can show a lot of videos, and I want to show videos, and we are showing videos, but if I can leave you with the most important thing, it's not specifically an actual surgical technique, right? Which I want to mention one more thing, by the way, and then we'll get back to this case. Pay attention to the hands. The hands are the secret, right? There's a couple of secrets. Number one is visualization, right? Visualization, man, that is the secret to ophthalmology right there. If we can't see well enough, then we lose our superpowers, so to speak, right? I would rather invest, for example, in the best microscope than invest in the best phaco machine, personally, because visualization, I mean, that's the secret to opening up the uncertainties, and that's important. Number one. Number two, get a degree in physics. There's no excuse for any of us to not have an underpinning in physics, and that means the physics of how tissue behave, instrumentation we use, fluidics, power delivery, optics. We have to know this stuff. I hate to say it, but the majority of folks, including people who come into this fellowship, including residents who start residency and they're finishing residency, have a very poor grasp of physics. If you want to do the usual and do your regular routine phacos and do 20 cases in a day and get in and out, then you don't need to listen to this talk. Of course, I don't think you do. If you want to do anything more to handle difficult cases or have more meaning in the OR and more meaning in life, then understand more. I think that's, I hope, what I'm mentioning. And this is, again, where not just looking at the video, but looking at hand position. The other thing I miss is people visiting in the OR. It's amazing what you can learn from being in the OR and watching how a surgeon holds their instruments. For example, putting in stents is an example here. And looking at different views to help to, understand the arm position, the wrist position. And a number of us are writing a book. It's a step-by-step illustrated guide to complicated eye surgery. In that book, we don't just show the actual surgical footage. We show how to hold instruments, like the pencil grip, right? The pencil grip, right? We show the cigar grip. Like Federico, man, you're a big cigar guy. I'm sure you're smoking cigars, right? We do the overhand grip, right? Okay. And then we show the underhand. And all of these approaches are so helpful for us to then teach what your grip is, how you're gripping things, how you're holding things, because that can make a huge difference. And that's the biggest reason why I see people say, Ike, I watched your video and man, you're a genius, man. You do that stuff. You're amazing. I had trouble. I couldn't do it. And the first thing I think about is, how are you sitting? What's the microscope position? What was the head position of the patient? Show me your hands, how you're holding instruments. Where were your incisions? How was the exposure? And so on and so forth. And that's the kind of thing which is really important, especially when we're using micro instruments or we're using, fine instrumentation. And we're going to be doing, some teaching techniques on how to do video. And I'll be talking about GoPro videos. Thank you, Jason Zhang, for writing on my presentation, Jason. I know you did it. See, I changed the settings here, so I see I did annotations. This is just showing you Lotero from Panama, really smart guy. But look how I'm injecting in my left hand here. I'm not using my thumb like we normally would inject. I'm using my first finger. Why? So I have the rest of my hand resting on the patient's forehead to support my hand, rather than just using the typical injection with the thumb like we normally do. So little things like that. I'm lucky I have big hands. I'm really supposed to be an orthopedic surgeon, but that does help. But you can just see how I'm holding instruments here, which allow us to, again, inject into the eye without having problems, without having a tremor, without other problems like that. So that's what we wish to see. And yes, we want to have, it's going to be an ebook and a paper book from Slack. So write to Slack and say, I'm waiting for Ike Ahmed's book. It'll come out, it'll be really cool. We'll show all these footage with video as well as hand positions, and it'll be hopefully helpful. Okay, so you can see I can talk for a long time, but let me go back to this case here. Milton, did anybody want to say anything while I get this set up?
Yeah, we have the open mic for several speakers and
sure, yeah. I'll let the video play while we're doing this, because we've heard already about different approaches, and I'll let the video play. But go ahead and speak up. We have vitreous concern, right? We have the iris that's torn. We have potentially atonic pupil. We have capsule plaque, which Bruno talked about. We have sublux lens, right? We have all these problems that we think about. So list the problems first, right? Like we do in typical medicine. Luckily, the plaque was central. So I was able to do a rexus around it and incorporate it around it. I want to manage the iris after, by the way, because I just feel I can have more control when the lens is out of the eye. But I put some iris hooks in and some capsule hooks in to support the iris and support the capsular bag separately. And that's something that I find to be helpful. Look again, look. Before coming out of the eye, what am I doing? I'm injecting viscoelastic or BSS, whatever you choose. Now we've cleared the bag and we can remove the instruments. I'm going to put, okay, I want everyone to stop for a second and pay attention. Okay, what is this device I'm using here? Everyone write it down in the chat group. What's the name of this device? And if you say the Sioni ring, I'm going to kill you. If you say Sioni ring, I'm going to kick you off this call. Okay? Yes, it's a capture tension stack. Wow, everyone went crazy with that one. Yes, which is a nice device. But we can do Sioni ring, will be fine as well. Now notice my landmarks, by the way. Sometimes we don't talk about the landmarks. I want to mention something here. The limbus is not the best place to use as a yardstick because the limbus can vary patient to patient. A big eye, the limbus may be more farther away from your suture site than a small eye. Instead, look at the blue zone here, okay? And when you see the blue zone, you know that's basically coming toward the beginning of the scleral spur. And that should give you a tip. So remember here, this is the limbus here. This is me writing, by the way. Okay, and that's the limbus, right? Again, I don't want to use a limbus. This is the blue zone here. This is the blue zone here. Right? Everyone see the blue zone here? Right?
Yes.
Okay, good.
Yes.
This is the end of the blue zone right here. Okay? And then they have what they call the white zone, which we will say in orange. Some people call it the white zone. If you basically go back 1.5 millimeters from the end of the blue zone, the transition zone here, and you go back to here, this is basically will always put you where you have to fixate the lens or suture. Notice here, for example, is farther back. This is a myopic patient. If you're not sure, you should go at least 2 millimeters back from the limbus, at least. And that's why, for example, Yamani technique is 2 millimeters back from the limbus. But it doesn't work if the patient has a very big eye. You may have to go back farther because you have somebody who has a more posterior position of their zonual plane. I call it the zonular plane, where the IOL should be sitting. So those are some landmarks. Let me clear everything here. So I made the incision there because that's where we're going to be suturing the incision here. And then We're gonna pass our sutures. Sorry, right there. And again, I've showed this technique many times. I won't go through too much detail, but I use Gore-Tex suture. I still like using a 25 gauge needle to go above the capsule, capture the docked needle with the Gore-Tex. This Gore-Tex comes in a curved needle. I like to straighten it out, make it straight. It's easier to pass. And then we have a continuous loop of suture now that will do a slip knot. Please, a slip knot is great to use when we're trying to titrate tension, because I don't know the final tension yet until we actually end up, with the IOL in the bag. Yeah, Tiziana is here. Thank you. I know she's been here. Thank you for answering the questions. Tiziana knows all the answers. She should know all the answers. So thanks for doing that, for answering everyone's questions. CTR goes in because CTR is helpful to avoid, to provide more circumferential tension. Now here's a little pearl. Again, what I'm trying to do is just give you what's in my mind, right? It's the best I can do. I can't say I'm better than anybody else. I can't say that this is the only way to do it. But what I can say is what I'm thinking. Because the best thing, when I see people coming to watch me in the OR, I could have 4 people in the OR, right? I could have Victor, Federico, and Pedro, and Mateus. They're all watching me in the OR. And one person gets it like this. And the other 3 people have to watch it many times, right? Why is that? Is that person so much smarter? Do they have a higher IQ? Not necessarily. It's because they knew what to look for, because they asked questions in their mind. Why is the person doing what they're doing, right? Well, why am I doing what I'm doing here? Is because I've had experience where everything is great right now. I put the IOL in and the haptic unfolds prematurely. And now the IOL is not fully in the bag and now I have to push it into the bag. No problem if the zonules are fine. But when the bag is weak and moving around, pushing that final optic in there, I've had problems where sometimes the bag breaks, sometimes the zonules get further weakened. So I thought, why not suture it? This was the original thought. I think other people have thought about it. Dick Bakul told me he tried this as well. And basically, I just sutured the haptic temporarily. So now when the IOL goes in, it's so controlled. And believe me, I've done enough of these cases. Everything going great. IOL goes in and boom, you've ruined everything because the capsule is broken because of the tension. It's a big object coming into the bag there that's weak. And then we move the haptics where we want to put them. And then basically we can essentially then cut the suture. We will lock the knot and then rotate it in. Always rotate Gore-Tex. Never leave the knot on the surface of the eye. And now we have to do with the dialysis. This is a pretty big dialysis. This is about 6 clock hours, and there's a small area nasally as well. Micro forceps can be really nice to allow us to see how much iris is there, and usually there's enough. I'm using now a straight needle, which I find easier to do dialysis repairs, but it's very long. So notice I bent the end by 90 degrees to allow me to not get caught by the lid. Again, it's a small innovation, but we did it because of my experience and thinking to say, what is the problem? How do I fix it? And you can see that the pass is made. We'll do multiple passes. We try to grab the peripheral edge of the iris. And then again, we do multiple slip knots. This is tenoproline. I'll just forward this. I did 3 mattress sutures, 3 of them. There are other approaches too, like the sewing machine technique, but I find this to be predictable and it leaves small openings in the iris. And then we can tie. Now, don't tie too tight. Otherwise, look what happens. The pupil can become distorted. So I actually didn't tie it very tight. I let it hang back a little bit. And I have to do one more step here. Now, the other thing I'm going to mention is, those of you who do complicated cases, I know that Lucan has been very active here. Lucan is an amazing surgeon. Check him out online. Stamina. You need to have good stamina because, man, this case is a long case. Have a comfortable cushion, right? Sit down, be comfortable with your body, and don't rush. Don't rush the case. I see people rushing to get out of the OR at the last minute, and man, you miss the opportunity. And so I do one more suture because I have to also be a perfectionist. I didn't want to leave the patient with a distorted pupil, and I tried to reduce the distortion of it. And that's basically how we managed this case. So, Victor, each question is a very complicated answer, but that was my long answer to your case you showed. All right, are we going to continue to move along here?
Excuse me.
Yes.
One of the residents has a question, and he wants to know, how did you practice to have such a great performance with both on your hands, and if you have any training tip to practice at home during this quarantine?
Yes, I have a few things to mention about that. So first of all, I'm somebody who is very prepared. I'm over prepared in my mind. So I'm always thinking in my mind. Like for example, sitting here, I have a couple of pens in my hand. Sorry, my door's ringing, and I'll be flipping around in my mind, thinking. I don't know if you can see me here. I'm closing my eyes and I'm thinking. I'm in the eye. I'm doing certain things. I'm going in like this. I'm using both hands. That's the first thing. Number one. Number two, all of you who are right-handed, stop using your right hand for the rest of the quarantine. Stop using your right hand for the rest of the quarantine, okay? That means whether you're writing, using your mouse trackpad, eating, brushing your teeth, and maybe when you're lonely at night. Okay, you can imagine what you think, what you want, but use your non-dominant hand. When I was in my fellowship, I broke my right hand. My right hand was broken. I couldn't use my wrist for 6 weeks, 8 weeks. And my preceptor was wonderful, Alan Crandall, and he basically said, use your left hand, Ike. And since that day, I've been working on that, and really, it's for me been a godsend because it's allowed me to be comfortable. In fact, I used to do my laptop. I have it in front of me with my right hand. My you know the trackpad, right? And I went to my left hand, and I still now only use my left hand only, because the trackpad is very good to work with because we use laptops all the time, and a trackpad is really good to do that. So that's what I would say. Number one, a couple of points on that. And so do that. Number three, yeah, you know what? These webinars are great. Watch videos and then try to get some practice eyes. We did if you go onto my YouTube page, you will see one of our previous rounds. I think it was last week. One of my fellows, Valentina, presented with Stuart Stoll and Nicole Fram, part of a section on using artificial eyes to practice Yamani, to practice different techniques. And that can be used as well to do that. But you don't need even to do that. You can write it out. I would think of doing this case I just showed you. Anna did a nice job on the chat group, and write every step. Right here are my 10 things I got to be concerned about. Here are the 10 things I want to have in my OR for it, and then write every step down. Every step, write it down. And then in your imagination, sit down like in a virtual simulator. This is my virtual simulator right here. I'm sitting in my OR. I'm asking for an instrument. I'm going through my mind. I'm doing everything here. Now, I do this fast now. I do it in the shower. I'm talking about practicing in the OR. Don't think anything else. And I do it when I'm sleeping or I'm going to sleep. I'm doing all those things. My mind is going crazy with it. And you may be thinking, Ike, I'm a resident. I'm not going to be doing this case for maybe a year or 2 or 3 years. And my fellows, the same thing. I tell them, you know what? Do it every time, because now when you're going to be in the OR, you'll be ready. Mm-hmm. And it sounds like it's very long and very difficult. And that's why most of you won't do it. Most of you won't do it. But that separates the really high achievers from the other ones. It's not because of skill. It's because, you know what? You had the stamina and you had the passion and the energy to do it. So quarantine is a blessing for everybody, in my opinion, from this perspective, to be able to do that. By the way, one more shout out to my team. I'm a big proponent of a team. Any success that I have is because of people like this who I work with. And I even have the blessing of people visiting in the OR who add to the climate. So, yeah, it's basically a huge team effort.
Good afternoon. Nice to see you again.
I have a question.
Okay, who's that?
Can I go first?
Yes, please.
Ike, which advantage do you see using CTS and CTR over the Sione ring?
So when I finished my fellowship, we had the Sione ring, right? Sione ring is obviously a great approach. It's wonderful, but a couple of problems with the Sione ring, in my opinion. Number one, the Sione ring really only works well when you put it in after you remove the cataract and the lens material. Putting it in before and using it to support the bag, it doesn't work well. But the segment you can put in before and use with an iris hook to support the bag. That's one thing. Number two, suturing the Sione ring and then putting it in, it can get quite messy and quite challenging. And so separating the two, I just find to be a lot easier to do in terms of separating out those functions. Of course, there's an extra device you have to get, which I understand the reason for having a concern for it. But I find that separating them out like this can provide a lot of help. I don't need to use a full ring either all the time either. So sometimes I don't put a full ring in. If I'm worried about the anterior capsule, if it's torn, I can put the segment in another area still. I can't put a ring in. And so I just find that I had too many problems with Sionia ring. Sometimes you put the Sionia ring in, and it's so difficult to put in the bag that's very small that it ends up causing more problems. So that's been my experience. But again, I have no ill feeling about Sionia at all. He's obviously a good friend of mine, and I know he uses both devices as well.
Okay, perfect. Thank you.
Dr. Ike?
Yes, someone else was asking, I think.
Oh, there's someone else?
No?
All right.
You're the somebody else. You're the one who's somebody else.
Okay, then.
Who's this? Who are you?
This is Aline. I'm from São Paulo, Brazil. And I would like to ask if you have any special advice or anything you would say to the approach of the patient when talking to assess if the expectations from the surgery are realistic or not. What would you say about this?
I think you make a great point. I mean, matching expectations are really, really important. So, I mean, that pre-op discussion is really targeted toward what can I deliver and what the expectations are. And so I always try to lower expectations. Even if I know it's going to go well, I try to always lower the expectation to what I can achieve and to be realistic as well. And not just the visual acuity, right? But the post-op recovery, the complication risk, the visual result, for example, like this. Someone thinks my eyes are going to be normal again. We'll have to tell them, no, it's not going to be normal. And like Widya said, under promise, over delivered. Exactly, like Raphael, smart guy too. So that's kind of what I would say. What often is missed on this, and my fellows, I mean, Tiziana probably can talk to this. She knows when I'm in the room with a patient, I mean, we take our time. I mean, we take our time when we're talking to that patient. We don't rush them out. We cover everything. It's a pretty big discussion. But most important than that is don't be a robot, right? Most important than that is connect with your patient, because you can go through every single expectation in the book. But if you don't connect with the patient, then you lose that patient-doctor bond. So I think hand in hand with expectation discussion is making that connection as a doctor. That does not take half an hour. That can just take a few minutes, how engaging you are and how interested you are in that patient. And they know it when you see it. If you walk in and they can tell you want to leave, or they can tell you think about something else, they can really smell it in your eyes. If you're underconfident and you're fearful, they can sense it in your eyes. Now you're a trainee, I think, right? A resident, right? So that's okay. You don't know everything, but you can still go in there and you can do that better than I can, even if you choose to do that, by making a better connection with the patient, right? And that will be what the confidence is to help the patient to get through the result. And then the one thing I want to mention is we lose the issue of empathy. I always put this slide up here. This was a live surgery I did. I don't remember when. I did too much live surgery. I forgot when I did it, but I did one recently. This is the patient. I think it was in Barranquilla, I think. Yeah, I think it was. Or maybe it was in Spain. I forgot. Anyways, it was a big case. And man, this moment here is the best moment, right? This is what we have to remember when we think about our patients and the cases we're doing, is the human being behind it and the oath we took to take care of that patient. Right now, we're stuck not seeing patients a lot, but we're calling patients on the phone because they're worried about their eyes. Feco Elche, thank you, Pablo. Feco Elche, sorry. That's what we did that in Elche, Spain. And that connection is reinforced now during COVID, because it reminds us that we're not just technicians, we're physicians. So I appreciate you bringing that question. It's so critical. We don't teach it well enough, and we have to remind ourselves for that. I think that's a really good point, Alina. So thank you for mentioning that. Where are you studying at?
Thank you. Now I'm doing in Ipepo here in São Paulo.
Okay.
I'm a trainee of cataract. Yeah.
All right.
And before I was in Santa Casa, which is also in São Paulo.
Yes. Okay. So it only takes you like 3 hours to drive from one to the other, right? In traffic?
Yeah, it's more or less like that.
Thank you, guys. Thanks for that question. Hey, man.
Thank you.
Hey, how's it going, man? Gustavo here from Belo Horizonte. And
hey,
my fellow,
Gustavo.
Hi, how's it going? And my fellow is asking, in such complex cases like the one you just presented, do you take extra caution with IOP after surgery? Like, is it routine for you to prescribe hypotensors or something to lower IOP, or any extra care due to inflammation or cystoid macular edema?
It's fantastic points, my friend. Thank you for mentioning that. So I didn't talk about the preoperative pharmacology, about preparing the eye, antibiotics, steroids I use preoperatively to keep the eye quiet. But after surgery, yeah, I mean, as you saw, I'm a glaucoma specialist, as you know, by nature. My patients have viscoelastic in the eye for sure, left in the eye. Now, in these cases I just showed, when you make scleral openings, sometimes we have flow through the sclera because of the needles we passed. So keep that in mind. One thing I often do is I check the patient's pressure the same day. Because if they're going to spike, it's going to happen in the first 3 to 8 hours. By the next day, they've already probably passed their peak. And I use that as an opportunity, if I need to tap them right after the OR if we need to. All my patients who are like this get more steroids. Sometimes we inject it. And we have a low threshold to prescribe acetazolamide. We give them 250 milligrams, and we'll give them not just one dose, not just two, but maybe 3 or 4 doses every 4 hours or every 3 or 4 hours for the first 24 hours if we need to control the pressure, because that certainly can be a problem. But I find going after all the viscoelastic, it can just open up things terribly. You did all this work, and now I go with the eye handpiece and the suture breaks, or the chamber shallows and the eye well moves, or the vitreous comes around, or something else happens, right? So I just absolutely don't do that. And I do all those things to manage that. I can see the patients the same day, ideally. My fellows know that, of course, as well. And that's how I like to manage it, you know, and that's served me well over the years to help that.
Oh, great. Thanks. So you rather have a little bit of viscoelastic left in the eye and manage it with drugs, with pharmacology.
100% true. Now, I will remove viscoelastic manually. I don't think I showed that in all my cases, but at the end of the case, I will use my BSS cannula to go through the side port, hydro into the eye, inject into the eye, and then aspirate. It's slower, but it's more controlled. And I find that a lot of new surgeons don't know how to use manual techniques of removing cortex, like the Simcoe needle, and they don't know manual techniques of removing viscoelastic. Every resident should use a 27 gauge cannula. It only costs like a couple of dollars, and know how to remove cortex from the bag with a cannula. Every resident should know how to remove viscoelastic with a cannula without going in with the IA handpiece manually. Those are 2 skills which I know they're not like, wow, incredible skills, but they're skills I use every day to do that.
I've been watching your videos. This is now just a personal question. And I haven't seen you use a lot of two-way cannula. Do you guys have those there? Do you have to use them in complicated cases? Or
you mean like the Simcoe needle, the two-way cannula, the Simcoe needle?
No. A two-way cannula is one that has a way for irrigating, and another way you can control the aspiration with a syringe.
Yes, I know. I think it's like a Simcoe needle, basically. Then similar to that. I think I know what you mean. Yeah, I don't always do that because the problem with that I find myself is that, you know, like, what incision do you use for that? It's probably the main incision because it's a bigger needle, right? A bigger cannula.
No, actually, 1.2 incision is fine.
So you have to enlarge your incision then, yeah. So if you can go through a small incision, I think you can do that, sure, basically, and I know you can control it with your thumb or your other hand and just aspirate and inject. I think it's a good idea, sure. As long as you don't go through your main incision and then everything shallows out, I think it's fine to do that. It's a good idea.
Yeah, because with this two-way, you can control the inflow with your feet because it's the phaco machine, and you can also control the outflow, the vacuum, with your hand. So when you're using mechanized instruments, when you step to get vacuum, you are already inserting fluid. And this way you can set a little bit of fluid and immediately aspirate it, or even though dry aspirate it. So
I think it sounds great. And I just saw a comment about some folks who are making these micro Simcoe cannulas, high flow and thinner incisions. So yeah, I think those would be very good ideas to do that. Bimanual can be an option too. I just don't like all the irrigation. I like the irrigation to be really controlled in my experience. That's what I do. I put this slide up here because I think this is a nice slide to explain how to look at complicated cases. The complicated cases are really simple problems that are put together into a bigger issue. And if we can break down those simple problems into discrete steps, and perform them together and well, then it becomes a simpler problem. So this is the mantra I have up for me all the time is, again, complexity is simplicity multiplied. And I think that's just kind of a way to think about handling these more difficult problems.
Hey, hi, Ike.
Hello.
Hello, how are you? Going back to that aerodialysis case that you presented.
Yes.
We know that all of those trauma cases, and especially the aerodialysis cases, are under a great risk for developing glaucoma right away or sometime in the future. And one of the components probably is some scar tissue formation on the angle. And so sometimes I worry when we have this big aerodialysis, when you fix it with sutures, maybe you're adding more tissue to the angle, and that may increase the risk. So what are your thoughts on that? Maybe in those cases, I usually prefer to use some kind of iris prosthesis, especially the human optics. I think it's a good one. But then there's the topic of cost. Not every patient can afford to use that. So what are your thoughts on that?
Yeah, I think those are good points. I definitely prefer to use a native iris myself. I think having a prosthesis in the eye has its own set of issues and complications that can happen. Of course, I like prosthesis as well. Don't get me wrong. I like the human prosthesis, human optics, and other prostheses as well. But I think there's always going to be some plus and minus in them, cost aside. I have not found this to be a major problem. Now, remember, of course, these patients are at risk for glaucoma anyways with traumatic angle damage or angle recession. So we know that. This patient also has 180 degrees of the angle that is untouched, right? Inferiorly in this case. So we have a patient who has inferior angle, which has been untouched. And then lastly, when I suture the iris back again, it's important to know the landmarks. This is where, again, we want to look at the eye and imagine where we want to make our landmarks here, right? So for example, we talked about the limbus here, right? So we don't typically want to use the limbus as a landmark. Again, not a good idea. So stay away from the limbus. Instead, we can see again where the blue zone is, and the end of the blue zone, you can see basically is right about here again, in that direction, right, where it's blue. That's why I put in blue this time. So I wised up on that one. And then we have, again, the sclera or the white zone behind it. If we look into the anterior chamber, remember the white zone basically here should essentially line up very close to where the scleral spur is. So if you go behind this, again, in this case, we'll go about a millimeter behind the end of the blue zone approximately, then we know that we're going to be putting the sutures here in an area that's going to avoid getting the iris too close to the trabecular meshwork. And so that's kind of important, again, for landmarks. So putting it all together, I think the risk is there, of course, but I have not found it to be specifically a major problem. I warn people, though, they could develop retina problems, they could develop cornea problems, they could develop glaucoma problems. They have to be monitored, but I think that risk is going to be there no matter what. And I don't feel the risk is necessarily higher by what we're doing here. They already have severe damage to their angle already because they've had a big dialysis.
Yeah, thank you.
It's a good point, though. Very good point. So landmarks, knowing our anatomy, really, really important here. All right, Milton, where are we now? Everyone still awake?
Excuse me. Can I ask you one more question?
Sure, Matthias.
I apologize if I'm wrong, but from
You're
what
wrong.
I see on from some of your videos, you use the trypan blue in almost all of your cases. But if that's true, why and when did you decide to start doing that?
No, I don't use trypan blue. I use it very little, very little. In fact, my fellow sometimes complains and says, Ike, you have a case of a dense cataract. Why not trypan blue? I say, no, we don't do trypan blue. No, not at all. It's very rare I use it. I use it more actually to inject in Schemm's canal, for example, to look at the aqueous outflow. I use it much more in those situations than this. The one time I use it all the time is pediatric guys. The pediatric guys, I do like to use it for sure. I do think it helps to reduce the elasticity of the capsule. And I do it for a very white cataract. Otherwise, I don't bother. No, I mean, no, not at all. For me, it's like no problem. You must have got a different opinion. That's my feeling. And even for example, using iris hooks. like, I mean, this people here, I'm not using Irish hooks for this case right here. No way. I'm going to use some intercameral lidocaine and phenylephrine, right?
Yeah, I thought I heard you saying sometime that you use in all of your case because of the
pediatric. Sorry,
the
pediatric.
ability to
Sorry,
to
thank you for
reduce
asking.
the
Pediatric
elasticity.
Yes, that's the main reason why we do that. But again, everyone has their own comfort level. You could use Iris hooks for that case or Trypan Blue for another case. It's I wouldn't say you're causing a problem though. Someone asked, how many challenging cases do you do per day? It varies, right? I mean, Tiziana said 2 complicated cases a day. I think sometimes it's like 4 or 5. Sometimes it's 1. It depends on the day. Sometimes we do a lot of glaucoma as well. So because of that, we have to balance them out. But it seems like we have complicated cases a lot.
Hi, can I do a question here? It's Renato from São Paulo.
Hey, Renato.
How are you?
Good, man. Looks like you're on a soccer field or something.
No, I'm in my house. It's okay. So let me ask you something. You are talking about anatomy. So I think it's important for the residents and fellows. And I always tell them this in the university. If they do extra cap, they will learn how to deal with anatomy and how to do with glaucoma or pars plana, vitrectomy, or everything else. So when you do you teach extra cap for them? And if you don't, when do you convert for extra cap in your case? How many cases per year do you convert?
Probably 0, to be honest with you. I have done sometimes when it's a dense cataract and it's a posterior capsular rupture. I think I have a video of that one from before. Otherwise, it's pretty rare. I mean, I had a black cataract that was really bad where we ended up doing intercap for. That was the one where I used a cryoprobe for the first time in my life. That was about 6 years ago. But it's very rare. I mean, now don't forget, in Canada, we don't get as much of the very, very, very dense cataracts. We do get dense cataracts, yes, but they're not, I don't think, as common as you see probably in Brazil. Like this case here, for example, this was a somewhat dense cataract in an aniridia patient. But I was, I like to use torsional phaco, and I find that I can still manage these cases. This was not the worst cataract that we've had, but so yeah, it's pretty uncommon, and that's a problem because when we have to, do an extra cap, then we're not trained to do it. Our residents are not trained to do it, and so sometimes they have gone around the world to do this, to do micro, small incision. But yeah, that's definitely a challenge. But it's so rare here to have to do them now in Canada, North America.
Okay, thank you.
It's a different story. Proline and Gore-Tex. So I always use Gore-Tex for the sclera. When I'm fixating any element to the sclera, I just found Proline can break. Now, if you're using a 5 or 6 Proline, it's a lot thicker. And so I think, of course, Canabrava and other people have talked about using that approach, or Susan Jacob have talked about it. I think that's acceptable to do that, of course. But if I'm suturing a device or anything, I'm typically using a Gore-Tex suture. The 9 or 10 Proline is, for me, just too brittle and it breaks. On the iris, it's a different story. On the iris, I think it can be managed well enough in most cases.
Ike, Victor here. Can we, after you show hard cataracts, can we start with the MIGS?
Sure, yes. Do you have a slide on that?
Yeah, I do the 3 first ones.
Great,
so,
okay.
Well, basically, I think I'm going to ask all of the questions first. So we know that, like, if you press once more, if you click once, yeah, we know that the Schlemm's canal is not homogeneous. How do you choose where to do your surgery when you do MIGS? Then if we go to the next slide, which, and you can press once more, please. And there are so many types of MIGS nowadays. How do you choose the correct one for each patient? And then if you go to the third slide, when we do MIGS surgery in general, bleeding is a very big problem. How do you deal with bleeding before surgery, during surgery, and after the surgery?
Yeah, I mean, Those are all good questions, I think, and we're still learning, of course, when it comes to the normal anatomy of the aqueous drainage system. We know that the canal of Schlemm. In most cases, you can make a catheter go all the way around, but it's not functional in the entire apparatus. So meaning there's only a certain area of the canal that may be functional or may be more prominent at any given time. This may be related, of course, to the size of the aqueous veins in the area. And I think that, what I like to do is try to look for where those veins are. It takes a bit of time to do this by looking on the surface of the eye, looking at the canal to see whether you see blood reflux in certain areas. If we're not sure, of course, I just put it in the infranasal area to work in, because that is typically the area where we see the largest area of aqueous drainage. So that's what I would say for that one. I don't think we need to open up the entire canal like, we do GAT and 360-degree GAT. I think that's overkill. I think it's too much, and there's more hyphema rates. If you're going to do a suture trabeculotomy or GAT, I think 180 degrees is fine. And I think we need to get more data to support this point. But anecdotally, myself and my colleagues here in Canada, many of us have felt that's to be the case. So that's basically what I would say. As far as choosing your surgery, again, we don't have a lot of head test studies. I will say that stenting approaches, stenting like iStent and Hydrus, are the safest, the least amount of hyphema, and they have I think the safest profile. On the other hand, there's a cost to it, and there's more technical expertise to put it in properly in terms of approaching it. So there's plus and minus on that. So when I combine it with cataract surgery, I generally go to stenting. I want to be able to cataract to go smooth and no problems after surgery. And if I'm doing it without cataract surgery, then I will still maybe stent, but I will think about doing more trabeculotomy. For example, either you can use a suture or dual blade or trabectome, goniotome. Any of these options can be done to cut the canal as well, or with viscodilation. We don't really have an answer which one is better, though. So I think that's still a question mark. I mean, excimer laser has been around for a long time. Maybe that'll be something. But each of these techniques, we don't have data to support which one's better than the other. And so when it comes to MIGS, basically the real question is, do you do MIGS or do you do something conjunctival? And I think that's the division for me. And when I go conjunctival, I'm choosing between Zen and in-focus pressure flow or trabeculectomy or tube. And that's kind of my decision tree on that, based on the progression of the patient and the target pressure. So it's a lot to answer, of course, in a quick time, but that's kind of what I would say, Victor, to that. And as far as hyphema is concerned, yeah, I mean, this is a problem we do see when we do open the canals. It's expected, of course. So number one, I never open, I should say never, I rarely open more than 180 degrees of the canal at one time, number one. Number two, I always keep the eye pressurized with viscoelastic during the procedure. And number three, I always leave some amount of viscoelastic in the anterior chamber. Like I will put, 1/3 thickness, 1/3, sorry, AC of the AC filled up with viscoelastic. And so that's what I've generally done with success. And I think the hyphema rates are less because of that. And I do stop aspirin and antiplatelets if I'm doing a trabeculotomy or GAT, because I do think that's a risk for those patients. So I hope I answered some of your questions there, Victor.
Thank you. Thank you.
Ike?
Yes, Milton.
Yeah, just out of curiosity, what are your opinions about the Yamani technique? Because it's being so widespread now.
Yeah.
But I think there are some aspects that could be reflected, discussed. So do you have any points?
I do use the Yamani, not all the time, but I do use it. I think that like any procedure in these difficult cases, there's always going to be risks. The one thing with Yamani you have to do is you do have to do a good vitrectomy. And you do, I think, have to use an infusion line, preferably in the posterior cavity. And so you have to be comfortable with doing vitrectomy, declaring all the vitreous. And that's why the vitreoretinal surgeons, I think, have gravitated toward this technique, because they're very comfortable doing a big vitrectomy and everything else. Anterior segment surgeons, on the other hand, it's not necessarily the major expertise for, and that can be where you get trouble, because if you leave vitreous around the sclerotomies, if you leave vitreous in the anterior cavity, you can end up having problems. That's the first thing. Second thing, the suture you use, the lens you use is also a factor. The lens material, the haptic material, can be bent and twisted and can cause tilting of the lens. And so the lens you choose ideally would be something that would be more indestructible, something like the CT Lucia, the Zeiss lens. Although we have done it with the Alcon and Acrosoft, as well as the MA60, as well as the Sensar lens from AMO as well, and the B&L LX61 as well. But I think it's just not as preferable in those cases in that situation. And then lastly, I'll mention that, of course, we have concerns about the haptic, erosions or extrusions. There are approaches like flanging the incision that Gerardo Valvecchi has talked about, and others. So those can be mitigated by those approaches, but you do externalize the haptic, and is that a concern? So those are all issues that you have to think about. Plus, you are interfering with the conjunctiva. You have to have good conjunctiva and sclera to do this. So for that reason, I don't always jump to Yamane. I will think about, for example, a very old patient, maybe an ACIOL even, believe it or not. I'll use the Artisan iris claw lens, which can be enclavated on the anterior iris or the posterior iris as an option. I will do iris sutured IOLs. Believe it or not, I mean, I have a long history of doing iris sutured lenses. I don't believe the risk is any higher than sclerofixated lenses, and there's less tilt. So, of course, if the iris is not in good shape or there's uveitis, maybe I'll be careful. So I'm a surgeon who wants to be comfortable with all the approaches. And if the cornea is bad, if the iris is not usable, then I go to the Yamane. Certainly I do that for sure. But then I do a good vitrectomy. I have a posterior infusion line. I have pars plana trocars.
Yeah.
I do vitrectomy and everything else. Those are all important things that I do as part of it.
Yeah, I absolutely agree with you, because that's the point. So many anterior segment surgeons, they think that it is easier than it looks, and I think it's a complex surgery. Lucan Michev has pointed out some aspects. Did you read that in the chat?
I saw Luca said something about he's a vitreoretinal surgeon, and he also likes iris suture lenses. So
Yes.
iris suture lenses. I see you there, Luca. Lucan is a very, very gifted surgeon. So thank you for your comment and being here. He's a good man. From Sofia, from Bulgaria.
Just as a reminder, I think we can have more 15 minutes more of webinar, because the host, which is Barbara Clemente, she has this time limit. So we're going up until 15 more minutes.
From now? Okay, great.
Just a quick question.
Hey,
Hi.
Daniela, how are you?
Good,
Nice
and
to see you.
Nice to see you. What do you do in IFIS cases? Do you have a special approach for these cases? Do you change something, parameters, viscoelastic material, incision,
So,
size?
yeah, I have to be honest with you. I used to change my settings. Now I don't. I have one setting, but my settings I make sure that I use linear control. Like, I love linear control. I know people disagree with me, but for me, I mean, having linear control, like if you look and see at my settings here, this is just an example here, but I have my settings so that they are set for linear control. So let me just show this here as an example. So you see linear power, linear duty cycle, linear pulse rate, linear control on the flow, linear aspiration, linear vacuum. And this is my chop settings. And the same thing for here. My longitudinal is off, by the way, for when I'm doing quadrant removal. I only want to use torsional. Torsional there, linear. So by having linear control, I can adjust what's happening in the eye as the procedure is going along. That's the first thing I'll mention. Second thing is, yeah, I do think there's a benefit to having some phenylephrine on board. Either you give them enough preoperatively, or you put it in the eye through an anterior chamber. And then thirdly, viscoelastics. Yeah, I mean, I typically use a soft shell technique. I like a dispersive, donut on the iris, and a cohesive, more central in the central anterior chamber. My incisions are generally fairly long, and I mean not too long, but starting in the limbus and going to the cornea. And I think I always operate in the center of the eye, anyways. So for me, it's not generally a challenge to manage those cases. But again, I'm a bit of a different story. Like I said, I tend to be a minimalist when it comes to some of these things, and I challenge myself. So I just want to see if I have a video for this, but maybe I don't have to show you. I don't have it in time. Yeah, I probably won't have it in time. Maybe I'll see if I can share it afterwards. But yeah, that's basically what I do to answer your question, Daniel. I don't really have anything magical. Oh, I should mention, yeah, Mulligan ring, of course, and iris hooks can be used as well. This is an IFIS case. The iris was not too bad, but I find as long as you do a good rhexis, I think you're fine, because I don't mind working through a small pupil if the rhexis is big enough. Like, to me, I think that the problems really exist when we have a small rhexis, and then we're trying to get the lens out of the small rhexis and cause the problem. The rhexis is big enough. I'm happy to work through a small pupil, because you know what? As surgeons, we should always be working in the center of the eye anyways. Our instruments shouldn't be moving beyond the central 3 millimeters anyways. So if the pupil's small, well, that should basically be what we're doing anyway. That's what I would answer quickly to answer that point, Daniela.
Thank you. And about those iris prolapse?
Yeah, I mean, iris prolapse, the key is prevention, of course, right? And that means not to overpressurize the eye. If it does happen, then we have to make sure that we handle it very carefully. But I'll show you one last case here. This is a small pupil, right? But look at my rhexis is big enough. My rhexis, I do it under the iris, and because I can look at the physics of the flap, I'm looking and seeing the way the flap is tearing. Remember I showed a picture saying, seeing the unseen. That's where we all want to be as a surgeon. We don't have to see what we're doing. We know it by muscle memory. We know it by visual cues of the flap, not of where the tear is happening. We're looking and watching where the tear is going, not where it's happening, by looking at the flap, right? So my rhexis actually is pretty good size. It's about 5 millimeter size, even though the pupil is small. And the pupil does get small during the case. That's okay. It helps to be a chop surgeon, by the way. A chop surgeon is comfortable working in the central 3 millimeters of the eye, whether it's vertical or horizontal chopping. And although you can see the iris is coming down here, I'm very confident in my fluidics, and I'm very confident with chopping inside the small space, and I know what to expect. Because again, as I've gotten older over the years, I've realized what really helps me in surgery is I can predict what's going to happen next. And that's the real experience that comes with doing surgery. Is if you're a great observer, you have the ability, it's a supernatural ability to predict what's going to happen next. So you can avoid things because you know what's going to happen next if you do something. We all do it in our life, right? We get burned once, well, we're going to make sure we wear gloves when we take anything out of the oven. We got burned once. Well, by observing the problems and knowing what they can be, we become that astute observer. So a surgeon, we think of doing, in my opinion, the best surgeon is the observing surgeon, the one who's very observant during surgery and only reacts when they have to. So go from being a doer to a thinker when you're in the OR, because that's how you can manage this case. So I'm just showing you my standard approach is I can get it done. I mean, and that's okay. Of course, iris hooks will be fine, but somebody asked earlier, I think Lucan asked, what about a dilated pupil? What about iris tears? That can happen when you put Mulligan ring, and it can happen with iris hooks. If you're going to be better with that, then use it, but every surgeon's going to have their own tools. Some of us fight barehanded with our bare knuckles. Some of you need to have a machine gun to fight, right? So choose your weapon. And yes, it's true. I'm not trying to show off here, but because I have a comfort level, you shouldn't put your patient at risk by saying, oh, Ike does it, I should go do it. More importantly, what I'm teaching you here is I'm trying to teach the thinking part of it, So sorry, I kind of went off on all these kind of tangents here.
Dr.
But
Ike?
I did want to make sure that I kind of commented on that. Okay, Deborah, where have you been?
Hi, I'm from Medical de Olhos in Curitiba, Paraná.
Oh my God, terrible program. I heard it's terrible there. Sorry about that. I'm kidding. Of course.
I saw that in your videos you use active fluids. And I don't know if you can explain for me what you prefer, gravity fluids or active fluids, because you have a lot of difficult cases and we need to stabilize the anterior chamber. So what you can have a tip with us?
I do love active fluidics. To be fair, I haven't used all the machines out there, so it's not fair for me to say this is better than the other machine, honestly. But I think the theory behind active fluidics, and now of course we can have the fluidics monitor in the handpiece now with some of the new technologies in the handpiece. And the future is we can measure the pressure in the eye. Imagine that. You can actually measure pressure in the eye rather than measuring outside the eye. That can give us potentially a real advantage. And then there's other technology coming down the pipeline I won't even mention, which can be pretty cool. But the ability to have active fluidics, I think is a real advantage because I think it helps to create a more dynamic situation for you when you're operating. I think that allows us to respond to surge and respond to variations in IOP by measuring it actively. So I think it is beneficial. Of course, you can easily bring the pressure up in the eye, or you can put your bottle height. You can hang your bottle really high in the ceiling.
Yes.
And that'll also be good. But then what's happening is, I believe you're putting too much pressure in the eye, and that causes more turbulence, and that causes potentially more volatility when the incisions are opening up, and it may cause more corneal issues. So I think there's a nice advantage at operating at a bit of a lower IOP, if you can. I think it can help you to perhaps be a gentler surgeon, operating a bit softer. But this is my own opinion, though. And I've used the Alcon machine and the J&J machine and the Bosch & Lomb machine. I think they all are very good machines. I don't want to say any machine's bad compared to the other one, to be honest with you. I think they're all really good. At this point in time, the machine is not causing a problem for you, believe me.
Okay, thank you.
But I love that you were thinking about it, because it means you're thinking about understanding phaco-fluidics.
Yes.
It means you're thinking about phaco-dynamics. And I think that is wonderful. So keep on thinking really deeply about how does the fluidics work on the machine? How does active fluidics work? How do these pumps work? What is post-occlusion surge? How do you minimize it? What's the difference between a vacuum-based pump and a flow-based pump? All these things, compliance in the tubing, how does that make a difference? Duty cycle, linear versus panel control of aspiration and flow rate. How do you set flow rate and vacuum? All these things like that are really, really good to learn that. I think it's great.
Thank you. Thank you for your time with us again.
No, thank you. I feel like I'm in Brazil almost, except I'm sure it's not as nice today compared to Brazil, I'm sure. Where's Tiziana? Tiziana, we got to see her. Speak up a bit. We got to see you. That's an order now. Quickly,
Barbara,
where are you?
Barbara,
Say
can
hi.
you open Tiziana channel?
Francesco, where are you? Tissi is from Fortaleza.
Hi, everyone.
I can't see you.
Oh my God, it's bad if you don't see me.
No, come on. Otherwise, you're fired.
Oh my God, no, please.
Okay, I'm not going to talk anymore then.
Oh my God, how come you do this to me?
Let's go. Come on. We're wasting time. We only have 10 minutes left.
Oh my God, why did you say?
Let's go.
Why you do this?
Over here. Okay, let me see you. Come on. There we go.
Everyone.
Tissie's wonderful. Such a nice person. And as you see here, she's learned a lot, and she's doing really great stuff. So we are happy she's here, and she's going to go back to Brazil. I'm going to try to keep her for longer here, I hope. But she'll be back in Brazil, and she'll be sharing all the words of wisdom.
Thank you.
Thanks for being here. Thanks for showing your face. She never does that with me, by the way. She never shows her face.
I do when I get ready.
Thank you for being here with us, Tissy. Milton, I'll put it back to you, Milton. What else you want me to cover? How much time do we have?
We have like 7 minutes.
Okay.
Just a reminder.
Tissy, you can turn off the camera now, Tissy. I'm kidding. Leave it on. Okay, Milton.
Just as a reminder, Gabriel Figueiredo, who was interacting here, he's the son of Carlos Figueiredo.
Yes.
Who was referred by Dr. Osher on Saturday on that beautiful, magnificent work, and you can comment on that also about the white cataracts, intumescent cataracts. The paper is very nice.
Yeah, I don't know. Is Gabriel here?
Yes.
Yeah, feel free to chime in, say something. No problem. But yeah, I mean, Carlos has added a lot to our learning on so many different areas within cataract surgery. So Brazil has had a rich history of great surgeons and great innovators.
Well, just as a last subject to touch on, can you talk about phaco-dynamics that is your preference in terms of, because my study group here, we were talking about these aspects in the last few weeks. We start our year by talking about two classes of very deep phaco-dynamics. And well, it's something that so many surgeons, they just set the parameters in the standard or the default, and I try to teach them in terms of thinking about each machine capabilities and how to explore it. So it would be very rich for us if we understood your rationale in terms of setting your parameters.
Sure, no problem. I just want to show this quick video. Someone asked about using cautery. This is basically from the phaco machine. We use 0 to 40%. Usually you need about 10% coagulation. Bipolar, it's basically a 23 gauge, like an endocautery here. It can be very nice to reshape the pupil. So that's something that consider doing. Okay, let's go to phaco-dynamics. I think it's a big topic. I'll just very quickly just talk about what we are doing. If I can find my slides. Do you see how many slides I have here? I didn't get a chance to talk about. I was going to talk about some personal journey stuff, but maybe we'll have to do part 2, maybe somewhere else, some other time.
Can we?
So basically, this is differentiating between, quadrant removal and chop. So a couple of things I want to point out here. Remember, the phaco tip has a different purpose for different parts of the procedure. And I should mention, by the way, I'm a chop surgeon, so I don't do a lot of grooving. If I do, of course, I lower my flow rate, lower my vacuum, and I'm usually a high vacuum kind of guy. I like to get things done efficiently. But I do differentiate when I chop, and I use a machine here, as you see here, that does torsional as well. So very quickly, chop, I want to have good holdability. I want to occlude, I want a lollipop. So for that, I want to have longitudinal phaco, no torsional, longitudinal phaco. I want to pulse it to be able to drive the needle into the lens substance. And I want to have linear control to increase the power, to increase the duty cycle, and reduce the flow rate when I'm doing this. I also want to have a high vacuum when I'm in position 2 as I linear control, but when I go down in position 3, I want to reduce the vacuum. So if you actually look at my vacuum control here, you can see that I actually have the vacuum going up and then down. If you look over here. Sorry, that's aspiration. Same thing with vacuum. I should mention both. So at this point here, the vacuum is the highest, but this is just at the end of position 2. So I've driven the needle into the lens substance with good power, and I come back off the foot pedal to position 2, high vacuum, I lollipop, and I chop the lens. So that's basically chopping. Now, when I want to do quadrant removal, though, I want to have less occlusion. I'd rather have it so I have no occlusion. So basically, I'm going to carousel the pieces. So here, what we're going to do is we are turning off longitudinal, only torsional, and linear control. And you can see my flow rate here. I'm keeping it higher at the end of position 3. Look at the difference between on the left side where my flow rate was like up and down, but my flow rate stays up. My flow rate does this. And my vacuum, on the other hand, is lower. Because here, I want to be able to carousel the pieces. So I want torsional, and I want to have a higher flow continuously in position 3. And I want to have less vacuum. I don't want to be holding pieces. So that's kind of very quickly, I know it's a lot, we could talk a lot just on phaco-dynamics, is just briefly how I think about my phaco settings, again, being a chop surgeon. And if I can play a quick video, same thing with my aspiration. Again, look at the linear, I have a high amount of vacuum, 760 cc's a minute flow rate, but I'm never going down all the way to the bottom of my foot pedal. I'm using linear control. I let my feet do the talking, so to speak. And just to show you an example of we start this routine cataract here. Where do I have it here? Just to show you quickly that that when I'm doing this, and in this case, actually, I ended up doing a groove too, but let me go right to the chop. Sorry. I'm multitasking with all these different videos here. So watch here, for example, I'm going to chop this. I have no torsional. Torsional is off. I don't want to make a bigger opening. I want to just grab this, and I want to have good holdability by driving it in with my phaco tip. It's a balanced tip I'm using in this case. Watch. I'm going to drive it in, high vacuum. Look at the vacuum buildup on the right side. Look how high it is, 615. 615 on the vacuum. So I hold it nicely. But I'm not in position 3 when I'm chopping. I'm in position 2. I don't want to be phacoing. I want to be lollipopping it. So position 3 is only to drive the nucleus, drive the tip into the nucleus. That's the only time I'm using position 3. Look at this. I'm position 2 here. See position 2?
Yeah.
Because that's where I want to be holding it. When I watch the position when I'm going to go in position 3. Well, now I move to the torsional. So now you see I have torsional on. I turn it off again. I go back to my chop setting. So see, I'm a surgeon. I go back and forth between chop and quadrant removal. Chop and quadrant removal. My settings are never the same for each part of the procedure because when I chop, the purpose is different when I'm doing quadrant removal. So I'll have to post these videos. I think I don't know if I have this video online, but I'll put it online if it isn't to talk about it. Okay, Milton, I don't know if are we still online or do we lose everybody?
Yeah, I'm online and I'm flabbergasted because
let's break the rules, man. Let's keep on going. We got 2 more hours. Who wants to go for 2 more hours?
I'll ask Barbara.
Isabel's here. Isabel's still here. As long as Isabel's here, we're going to do it.
We have.
Okay, Henrique's in. Iftikhar's in. Gustavo's in. Game on. All right, brother.
Hi, Ike.
Hi. Who's
Hi,
that?
I'm Aline from Porto Alegre.
Aline from Porto Alegre. Hey, how are you doing? I was just there. How are you? Nice to see you again.
Yes, I just want to ask you a question. I could see that you, to scope, you use your bevel up, and when you were chopping, you turn your bevel to the quadrant position.
Yes.
How do you manage this?
It's a really good point. Thank you for mentioning that. Someone else mentioned that before. I didn't answer it. So what I'm doing here is I'm a right-handed surgeon. So when I'm going to be doing my so here I have my phaco tip. My phaco tip here during chop is basically against the surface of the lens. But I think you're talking about it when I'm doing it, not yet, but over here, right?
Yes.
Right. So here's why I do this. Because look at my chopper. My chopper is I'm using my chopper to, carousel the piece.
Yes.
And so I'm holding my left hand. So I want the nucleus, preferably, if I had perfect scenario is, my nucleus is going to be between my phaco tip and my chopper. It's going to be here.
Yes.
If it's over here, then I don't have as good of a position with my chopper. So because I have my phaco tip, my piece to the left, I can use my chopper, as I'll show you here, to manipulate the piece to stay on my tip. Watch. See that? Very subtle.
Yes.
So that's why I do it. Now, that's my own technique. It's not necessarily the best technique, but that's what I do. Watch again. Watch. See, look. See, I move it. I move the phaco. I move the little piece. I want everyone to. It's very subtle here. I didn't just rush the surgery. Watch my left hand. I'm moving the piece after I chop it. Look, I bring it up. I move the piece with my left hand to get a better angle of attack. Watch. See, I move it off. I took it off my tip. I move it around. Now I go for it. And look at the holdability or the fallability. Look at that piece staying on my tip. It's not chattering everywhere. And I think the reason I have this because I attacked at the right angle. I have the bevel tip pointing to the left. So I can use both instruments to kind of sandwich the piece. And that's kind of what I like to do here. Here again, example. I have it, so I'm using it. So I'm putting it to the left. And I don't want the nucleus to be on top of my phaco tip. It's too close to the cornea. I want it to be beside my phaco tip, which is going to be away from the cornea. So I hold it on the side and I phaco it on the side for all those reasons. And I've never actually explained it so much because I have no time to explain it. So the fact you asked me this now, I actually have a chance to explain. I'm going to actually write it down. I'm going to write your name down so I remember you, Aileen. And by the way, you're supposed to visit me. Remember that?
Yes, of
I'll
course.
see you. I'll see you. I'm sorry about COVID.
Yes.
But yes, thank you for saying. I hope that explained it reasonably well.
Yes, yes. And when you position your tip glove, I don't know how to call it, you put the irrigation to the lateral of the tip.
Yes. Did you see that at the end where I have my irrigation?
Yes,
it's not always
yes.
perfect, but look at the irrigation sleeves.
Yes, it's it. Yes.
Oh man, sorry. Keep on going back.
Avoid cornea damage with the irrigation. Yes.
So it's not. It's a bit angled. It's like 30 degrees kind of angled. My sleeve. My sleeve is not perfectly lined up with my tip.
Yes.
It's offset. Offset, I guess, would be the word to use. Oh, and someone asked me, why do I use the light at the edge of the cornea? This was an aniridia case.
Oh.
And it was very hard to visualize the capsule. And I didn't use Vision Blue here because Vision Blue makes the capsule less elastic. And in aniridia cases, the capsule is thinner on the anterior capsule and more brittle. So I don't want to use it. So in this case, the reflection from the cornea was a problem because of the scatter of light, because of aniridia. So in this case only, I use the light pipe because it gives me side illumination. Look at the capsule flap, beautiful, by specular reflex. It's great. And then my fellow was just, I was just making my fellow work hard by having to hold a light pipe.
Perfect, great.
That was the answer to that one.
Thank you.
Thank you. Nice to see you, Aileen, again. I hope to see you again.
Yes, I hope to see you.
Okay, Milton, where are we going next?
Well, excuse me, Ike. Are you listen?
I can hear you. Yes.
Yeah, it's Gustavo Temponi from Belo Horizonte, Ipseng.
From Belo.
Yeah, if Milton allowed me.
Yes, go on. Go on.
Yeah, I would like to bring us back to the learning curve subject and asking you, as preceptors,
yes,
when should we encourage our residents or fellows to face complex cases like those ones that you're showing?
Yeah, I think it's a really good question. Obviously, it's a graduated responsibility, and I think I myself assess this. Don't tell Tissy this because then she knows my secret. But I try to look at I try to look at my fellows and residents in terms of their mindset. Like, do they have the proper approach, the attitude, the will, and everything else? Cognitively, do they have the right, problem-solving ability and everything else to kind of handle these things? And then the motor skills, physically, technically. Technically, usually is not a big problem, but the mental part of it, the preparedness of it, the problem-solving part of it, the cognitive part of it takes some time. And that's where I find people have a different pace to how they learn. And I think it's because it's not the usual way we learn. Usually we're taught, follow Gustavo, do step 1 to 10, and you'll never go wrong. And then that's all we think about. We just 1 to 10, 1 to 10, 1 to 10. It's from grade 1 we teach this to our students. We don't teach them to think. And that's the challenge. And so I think I have to tell them to do that. So once they get to that ability, then you know what? We've had some of our resident fellows do complicated cases from after their first 20, 30 cases even, because they have their really good preparation. They can problem solve cognitively, and their hands, and they practice their hands a lot. So that's what I would say. But I do think, and I do hope that resident fellows do complicated cases. I have our fellows doing complicated cases all the time. Not every fellow is able to do it, and usually it's not because of technical. It's because of the mental preparedness, being in the game, and or the cognitive part with that as well. So I think that's also important. I think that's a good tip. It sounds like Tiziana agrees with it. All right.
Okay.
Sorry, I'm still showing the video here. I should cancel that video.
And at this time of quarantine, our residents are getting very anxious because they're not doing surgeries. And I guess they are wondering if they will someday be a great surgeon. So as we know that it's a long road, which tip should you give to them?
It is a long road, absolutely long. It's a long road, no question. I think, first of all, I would say, listen, this is a short time in your career, and I hope it'll be short. I don't know how long it'll be, but your career is going to be a very long career ahead of you. Look at this as an opportunity. Look at this opportunity. I mean, I don't see a resident or fellow not doing well because they haven't done enough surgery. I think this is not usually the problem, although I think it can be, yes. But take the time now to really be able to use your mind and push your mind. You know how we push athletes to perform better. We push surgeons to perform better. But to push the mind is a hard one to do. But now you have the opportunity to do that, and take the opportunity to push your mind like you never have before, and try not to be lazy and do something with that. I would say number one. I think the preparedness part is something you can work on. Like I said before, there's three parts of it: there's mindset, cognition, and motor skills. Motor skills, you're sitting down, not doing anything. I know, unless you can do artificial eyes, fine, that's a good idea. But on the other side of it, the mental part of it and the cognition part of it, fantastic. I mean, that part you can really work on it. Learn from people, learn from mentors, meet new people. I've met new people. I've made new friends, which has been great. I love it. And so I think these are great opportunities to do that and to grow. The most important thing is, remember, this is out of our control. I mean, we can't control this. We're out of control for the most part. And so, worrying about something we can't control is going to be, it's not going to be of any benefit to help us. But in every situation like this, there's a way to make it, to get something out of it. And I don't mean to minimize it. I know it's hard for a lot of you here, but I think you're going to come out of this one strong and make a difference. Do something. Go and do something, and even online or something, help somebody. Honestly, I mean, whether it's helping someone who needs some food, giving somebody company, calling an older person who's living alone to talk to them, helping someone to get their groceries, do some. Goodness will always be rewarded. I don't know. I believe in God. Goodness will always be rewarded, man. You know what? If you're a good person, even if you are stupid like me sometime, I hope that God will reward you and will help. And so, that goodness will make you a better person and make you feel good as well. So that's what I would say. Honestly, I don't think I have anything magical to say about that. I think it's about an attitude. It's about taking this on, with the right attitude. And I think whenever we have a crisis like this, even personally, some of us will fall down, and so it's a matter of getting the right mindset. It's a matter, I think, of really, using our mind skills, which we never have to, we're not tested as much to do that. So that's what I would say. I don't know, Gustavo, what do you have any suggestions yourself?
Yeah. In my point of view, it works for me. I get more secure when I began to teach. So teaching is something that make us to improve better and faster.
Great idea.
I don't know if you passed through this, and how do you get to be this good surgeon that you are? Which way did you take to that?
Well, people often say, Ike, thank you so much for teaching, and thank you so much for doing a webinar. But I'm selfish. I do it because, like you said, Gustavo, it makes me better. It makes me think better. It makes me learn. It makes me think about other things. Even in this call, I have made lots of notes while I'm doing my talk. Lots of notes here, because I'm learning from you all. I'm thinking about other ways to think about something. The questions that many of you asked, the residents asked. I have a list of things I'm going to now read about and think about and conform a little bit. So, I mean, it's a great process. I think, thank you for mentioning that, Gustavo. And everybody can teach. Anybody can teach.
Always learning, right?
100%. Great pearls. I love that. I love it, man. We're on the same page.
Thank you, Ike.
Well, thank you. Like I said before, I don't necessarily belong to be in the position to be the one lecturing. It should be all of you as well who've done great as far as teaching that, understanding these principles. So Milton, where are we here? We have a miracle still.
Well, if you have something to share about your personal journey, I think it would be awesome. Because I myself heard some stories of yours.
Yeah, sure. I can say a little bit of it.
Yeah.
This is my personal journey right here. Okay, this is my philosophy in life. Just do it. Just do it. But literally, I mean that. I mean, too often we're busy thinking about ideas and everything else. And we don't do something, you know. And I think we have to be able to move. I realize in the quarantine it's hard to do that, but so much of it is actually doing something. And I think that we all have to have our values. And I put this up before because I was asked to talk about myself a little bit, which I don't like to talk about myself. But you know, for me, it's very much thinking differently. And no matter whatever I think I may have accomplished, and I don't think I've accomplished a lot, or whatever anyone says, I am always an outsider. I'm always different than what you know what other people are, and I never really you know fit in with people. I never fit in with people. I'm a misfit. Really, I'm a misfit. I'm not. I don't belong with the crowd, and I'll tell you more about that. Why maybe. The other thing I'll mention as well. I think that I hope that you know, I bring. I'm very passionate about what I believe and what I love. And if I love something, man, I'm so passionate about it. Like I have the sole purpose of that. And another thing is compassion. I mean, to me, when I was younger, you know, I was brought up. Let me say, I was brought up in a small city in Saskatchewan, in the middle of nowhere, and I was an immigrant family, a Muslim immigrant family, brown family that nobody else was like us. And so I never fit in from the beginning. And it was definitely difficult. People would make fun. People would punch and try to beat me up. And I wasn't as big back then, right? So I couldn't defend myself. But I really appreciated when I had one stranger be so compassionate with me, right? And so that kind of compassion never leaves you as far as what it makes you feel. It's okay to be compassionate when you're happy. People are compassionate with you, great. But the compassion really you feel as an individual when you're down and somebody comes up as a stranger and is compassionate with you. Like that is moving. And that's a value that I hope that I always try to keep because, you know, growing up in a small town, I think did impact me, you know, playing hockey and being the only person of color playing hockey and the different religion, different way of life, it stood out, stood out. So as a kid, I remember, you know, my name is Syed Iqbal Kareem Ahmed, right? Like that's a difficult name. And I want to change my name forever. In fact, as you know, when I was young, my name became Ike and I was happy with that. I was Ike and I'm still Ike, as you guys all know me. And I did that because I was hiding from my real identity because I was, you know, I didn't like to be made fun of. No kid wants to be made fun of. But as you got older, you realize, you know what, there's something about your identity that is who you are and you never can change that. So, you know, making it and using it as a strength now, it became a superpower for me. It became a superpower in that being an outsider, being different, being lonely at school, being lonely on the hockey team, that's okay. Because when I see a problem or when I'm in another situation, I have an automatic ability to, you know, see something differently that people don't see. And I had to break the rules growing up. I had to break the rules. Otherwise I couldn't survive. I had to basically do things other people wouldn't do because I had to get through it. Being different, I think, allowed me to do that kind of thing. And I just want to say one more thing is that being different is fine, but we have to be careful not to be so out there that we're trying too hard to be different, right? Let it be yourself, and everyone's gonna have their own story. All of you, I'm sure, have had a difficult story or a challenge in life, or you're going through a challenge in life now. And I think you'll find a situation where, although you're following people, as you do this right, you're going to find yourself that you potentially could be the one who's followed. And I find it surprisingly now when nobody ever wants to follow me when I was growing up. I mean, I was uncool, brown guy, you know, Pakistani Muslim, right? I mean, I would be the last guy picked on a hockey team forever, right? And even in university, right? Totally uncool and still uncool. And so nobody ever wants to follow me. So now it's hilarious that anyone wants to follow me. I feel like, wow, that's a privilege. And so, you know, maintain that, keep your, you know, your attitude and your passion. I just wanted to share that. I don't want to make it too dramatic, but for me, that was my strength. My weakness became my strength. My identity I was running away from became my identity I wanted to become. So that's basically a bit of a personal stuff.
Yeah, and I don't know. May I tell about the story I told you yesterday when I first saw you?
Please. Yes.
And I really want all the guys to pay attention to this story because it illustrates Ike Ahmed, seriously. And the first time I saw him was in the ASCRS 10 years ago. And actually, I didn't see him. I watched him during a live transmission at one of those corporate breakfasts in the morning, early in the morning in the Congress. And at that specific live transmission, there were some centers in US and strangely one in Canada out of the blue sky. And as all the people in the audience were in their breakfast watching the presentation beginning, suddenly a face appears, a giant face appears on the screen with a rock and roll hair. And you know, and there were two main behavior at that very moment, and I paid very great attention to the reaction, and that is what imprinted in my memory. First, there was a silence, a astounding silence, because who's this guy? And I knew why they all were so quiet, because actually they wanted to react surprised. And then after the very short silence, then came one or two, and then many of the audience laughing at this strange, very strange guy who was, you know, it was a talking head with large hair and presenting the case. He was not aware of the reaction of the audience because he was in Canada. And I told him yesterday because he didn't know this reaction of the audience. And I'm not judging everybody because it's the first reaction. It's very natural from us. But anyways, now everybody knows Ike, and everybody is used to the different. And it's very important. You know, Saturday, when I was watching Guardians of the Lands, which was promoted by Ike, one of the things that impressed me, other than the technique and the superb level, was the variety of persons who were at that webinar, not only in terms of race, but also in terms of gender. Because, you know, I think we are very dominated by men, and it's not the truth. It's simply not the truth. And it was so refreshing to see the balance between men and women, as well as the races, as I mentioned, on Saturday. But this is a very strong point, you know, in terms of, as I said, now we know Ike, but 10 years ago, he was an outsider. He fell out of the blue sky. So this is a story I have to share you.
Well, I'm the same Ike actually, so I'm no different actually. But it is a funny story. I still get a kick out of it when you tell me that now from yesterday. Yeah, I think that's the lesson, I guess, right? I mean, don't do things for yourself. Do things what you believe in yourself, and whether people listen to you or not, it doesn't matter. And do it with respect, I guess. So, but yeah, I'm glad. I probably at the time I'm glad I didn't hear people laughing at me because I just finished surgery. So
yeah. Yeah, may I share a personal story now that we are in this topic on the subject? Yeah, these behavior aspects, I love them. Not only about I not look only on technical aspect, but also on the behavior. And I was at this event in the beginning of the last year. and I was at the discussion table, and one of the doctors said that he could decide the fate of a wannabe surgeon in like in a minute, the way he handled the plate he was eating, and how he handled the knife and the fork, and actually I felt a pretty because I told him that I was not supposed to be at that table. I was not supposed to be as a speaker because I was not supposed to be a surgeon. I wanted to be so badly. I wanted to be an engineer, and I only turned out to be a surgeon because of my parents. They one of their sons should be a doctor, and I was the chosen one, but I wanted to be an engineer. So I really felt too bad every time I went to surgical operating room, and I felt bad when I had to make surgeries. But I always fought very hard in terms of conquering the skills and to overcome the limitations. And then I answered him. I told him, I'm a living proof that there is no label to anyone. I was not supposed to be here. And you know, after this event, on next day, a resident from Rio de Janeiro came to me, and she said when she heard the guy talking about labeling someone in 5 minutes, she started leaving the audience, and she stopped in the middle of her walk when she heard me. And she's a African American resident, a female African American resident, and that echoed inside me very much. And I felt that it's we as teachers, we are as experienced guys, we have to set the role model, not only in terms of technique, but also in terms of attitude and behavior. I'm so sorry for going so deep.
Yeah, no, Milton, thanks for sharing that. I mean, I mean, that's a beautiful approach to it, and I think we have an obligation for that, and we have an opportunity. So, you know, there's a lot of inspirational people here, even I see in front of us, who have done amazing work. And you know, whether you're somebody who's been in practice for 20 years or someone who's been a resident, never underestimate what you bring to the table, what you bring toward your field and the people around you. I mean, I started thinking when I was a resident, and some of my best ideas, I think my best ideas were things that I decided and developed when I was a fellow. And I find sometimes that people, particularly younger in their careers, don't give themselves enough, appreciation for what they can bring. And also I see some people, of course, have too much of an ego too. So ego can also be a problem as well. So we have to balance out that ego from that self-esteem and the confidence of it as well. And just remember as well, that it is, and Tissy reminded me this right now, that, you know, that it's easy to see great surgeons doing great surgeries, but we all were at a level as a resident at one time, and we all have had our struggles. I still have cases where I get a struggle from, for example. And of course, as you get more experience, it becomes less. But certainly when I started off, and I joke around and say I should bring my videotapes from when I was a resident, because I still have some of them somewhere, and play them, and you can see how it was for me then. And it's nowhere near as slick as I think I am now. And I think all of you don't feel like you're so far away from it. How are you going to ever get there? I think you will get there if you have the right mindset and the right, problem solving ability and the right cognitive features in your head thinking. It's not going to be because of your hands, though. I'll tell you that.
Sure.
Great. Wow. It's hard to believe that we've been 3 hours and it just feels like I've only been talking for 5 minutes. Or no, It feels like 5 hours, right?
No, when the journey is good, it goes without noticing.
No, it's really great, and I just want to thank you, Milton, for putting this together, and thank you for the the working group to put this together. Brazil is such a strong country with great people, and that's always, like I said before, what I think brings innovation and what really makes a difference. It's not the textbook, it's not the science, it's the human factor of it, and so that's the power. All of you have it in your ability to do that. Don't doubt that, especially the residents. I find that people are always, putting things into science or math or algorithms or artificial intelligence. Well, fuck that. You know what? We've got something that no one else can ever have, which is the human mind that God gave us. That's never going to be replaceable. And so no machine can outdo what you do. But you have to be hard. You have to work hard at it, though. You have to be able to tap into your brain. We only tap into a small part of our brain, as they say. We have to learn to tap into more of our brain, and it means pushing us. It means pushing us, like exercising your muscles. Well, it means you have to exercise your brain to think that level. But first, you have to decide you want to do it. And unfortunately, I don't think most of us want to do it because, like exercise, we don't want to be running and lifting weights and the stress of it. I guess some of us don't. So challenge yourself. It's great. I mean, I appreciate you putting this on, Milton, and I really enjoyed being with you all. I apologize for talking too much and for going off in the different tangents and the different direction, but I hope it did feel a bit more personal and more interactive and more, more of a give and take. And I love to keep in touch with people. So please stay in touch on Instagram or on Facebook or wherever else we may, because I mean that's our lifeline, right? Imagine quarantine back, during like the Spanish flu, or when there was no internet, even phones and stuff. And imagine that challenge. We at least have the ability to connect with people. So connect with people, man. Connection is it's the most sacred human feature that is incredible, man. If you connect with people, it's amazing. It's great. It's awesome.
I would love to thank the audience, the worldwide audience, and I would like to thank you so much, Ike, because when we were planning this meeting, we really wanted not to have a roadmap, as we said. We would want to give time for interaction among all the peers, and then going to discover by ourselves. So it was a blast, a great event. Thank you so much. I remember you coming to Brazil also to go to the Carnival Street, and I have a picture of yours at Carnival. Hopefully I will share one day.
Oh, maybe you don't want to share that. That might be a little dangerous.
Yeah,
but it was quite an experience. It actually was. I didn't realize, but there's actually a pre-carnival.
Yes.
Do you guys have a carnival?
Yeah.
And I mean, that's not big enough. You have to have a pre-carnival. So I was there for the pre-carnival, which was massive.
Yeah.
And I had a great time. Those of you that were there with me, I appreciate it. It was a little bit awkward when somebody stranger comes to you and they want to give you a kiss. But I figure I just went along with it. And that was before coronavirus. Now maybe I wouldn't do that.
And this mood of Carnival in Brazil, Brazilians take Carnival very, very seriously. And this is a good motivation for you to come back.
Well, I always will come back to Brazil. I think you probably have had enough of me, but I will find my way to sneak in to get back to Brazil. Always on my favorite list.
Good. Thank you so much for your time and your precious knowledge.
I learned from you. Like I said, this was a great experience for me. Keep in touch, everybody. I'll see you again online somewhere on a story or on a webinar or on email or somewhere. But stay well. I love all you guys. Peace, safety.
Thank you.
Well.
Bye-bye.
Take care. Bye-bye.